Okay, thank you and good afternoon. I'll call this meeting of the Northern Nevada Public Health District Board of Health to order. It's now Thursday, April 23rd, just 1 o'clock. And we'll start, Madam Clerk, with a roll call and determination of quorum.
Chair Reese.
Here.
Vice Chair Andriola.
Present.
Board Member Driscoll.
Here.
Board Member Anderson.
Here.
Board Member Brown.
Here.
Dr. Ituarte.
Here.
Dr. Rika Danko is not present at this time, and she's not online either. We do have quorum.
Thank you so much. We'll move now into our Pledge of Allegiance. Mark, and I hope I'm not pronouncing it right, is it Thayer, with our Truckee Meadows Fire Protection District President? Would you lead us in the Pledge of Allegiance, please?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Mark, thank you so much. Madam Clerk, public comment.
Comments heard under this item will be limited to 3 minutes per person and may pertain to matters both on and off the board agenda. Unused time may not be allocated to other speakers. Comments are to be made to the board as a whole, and virtual public comment may be taken when facilities are available. A speaker's viewpoint will not be restricted. However, reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant statements, unduly repetitious statements, and personal attacks that would objectively antagonize or incite others are examples of speech that may be reasonably limited. This board carries out the business of Northern Nevada Public Health and its citizens during its meetings. The presiding officer may order a person removed if the person's conduct or statements disrupt the order or safety of the meeting. Warnings about disruptive or conduct or comments may or may not be given prior to removal. Furthermore, certain disruptions of a public meeting are criminal acts as defined under NRS, which may result in prosecution in appropriate cases. We did not receive any public comments via email or e-comment.
Thank you so
We
much.
have no current request for public comment
Okay, we'll
for
close
this item.
item 3 out and just remind the audience that we also allow public comment on the individual items, and I think we do have some of those. Thank you so much. I'll go now to item 4 and ask Dr. Kingsley, are there any changes to the agenda?
None noted at this time.
Okay, thank you. I'll look for a motion.
Move to approve.
Okay, I have a motion by Mr. Anderson, a second by Ms. Andriola. Any other additional questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye.
Aye.
Any opposed? Motion carries unanimously. Item 5 is recognitions.
Can we just note that Dr. Danko is present at this time?
Thank you so much. And also, please, I'll remind everyone to vote on their tablets if you're able. Ms. Dixon, hello.
Good afternoon. For the record, Erin Dixon, Deputy District Health Officer. It is my honor today to recognize one employee for 10 years of service, Ms. Kelly Vierling. She is a CCHS Public Health Supervisor who's been with us for 10 years. She supports our maternal and child health program, and she ensures that our extensive Title X grant requirements are met, which is not an easy task. So we are very grateful that she is on our team. Thank you so much.
Fantastic. Thank you so much. Okay, we'll close out item 5. Item 6, we have several proclamations this month. Looks like we'll start with Drinking Water Week. And don't make me say that a bunch of times fast. Ms. Lord, thank you so much for being here.
Thank you for having me. For the record, Latricia Lord, Senior Environmental Health Specialist with EHS. And it is my pleasure to read this proclamation. Whereas water is our most valuable natural resource, and whereas drinking water serves as a vital role in daily life, serving an essential purpose to health, hydration, and hygiene needs for the quality of life our citizens enjoy, and whereas tap water delivers public health protection, fire protection, support for our economy, and the quality of life we enjoy, and whereas the hard work performed by the entire water sector designing capital projects, operators ensuring the safety and quality of drinking water, or a member of a pipe crew maintaining the infrastructure communities rely on to transport high-quality drinking water from its source to consumers' taps. And whereas we are all stewards of the water infrastructure upon which current and future generations depend. And whereas the citizens of our county are called upon to help protect our source waters from pollution, practice water conservation, and get involved with their water by familiarizing themselves with it. Now therefore be it resolved that the Northern Nevada Public Health District Board of Health does hereby recognize May 3rd through the 9th, 2026 as Drinking Water Week.
Great.
I think I'm
Thank you
supposed to
so
say that last part, right?
Yeah. Great. Congratulations. Thank you so much.
Thank you.
We'll move on to item 6B, which is Washoe County Air Quality Awareness Week. Mr. McMullen.
Good afternoon, Chair, Vice Chair, members of the board. Here to read off a proclamation for Air Quality Awareness Week 2026. Whereas poor air quality can threaten the health of our citizens and visitors, and whereas the increasing intensity, duration, and scale of wildfires has negatively impacted air quality in the western United States, and whereas children, older adults, and people with heart or lung disease tend to be more vulnerable to air pollution, and whereas the Northern Nevada Public Health Air Quality Management Division is responsible for managing sources of air pollution and assuring compliance with federal, state, and local laws governing air quality, and whereas the Washoe County Air Quality Trends Report, which contains information such as national ambient air quality standards, local ambient air monitoring network, and current air quality design values and attainment status, is available at ourcleanair.com, and whereas AQMD is dedicated to the protection of air quality and the safeguard of public health for all of Washoe County through the development and implementation of effective programs and regulations while supporting economic growth, community partnerships, and environmental justice. And whereas clean air will require a collaborative effort by all stakeholders in the region, now therefore be it resolved that the District Board of Health does hereby recognize the week of May 4th to May 8th, 2026 to be Washoe County Air Quality Awareness Week in Washoe County, Nevada, and encourages community action to reduce air pollution levels during this week and throughout the year. And I have a little bit to add on to that as well. So to celebrate Air Quality Awareness Week, the Air Quality Management Division is working with Northern Nevada Public Health Communications Team to provide information on social media each day to empower the citizens of Washoe County on the topic of air quality. Daily topics will showcase Air Quality's 5 Keep It Clean programs, which are Know the Code, Rack 'em Up, No Zone, Be Smoke Smart, and Be Idle Free. Also, we have a media event to celebrate the grand opening of our new ambient air monitoring station at Verdi Elementary School, planned for Thursday, May 7th at 11 a.m. We'd love to have you guys there if you're available as we showcase this important addition to our monitoring network. So thank you all again.
Thank you so much, Ben. Appreciate it.
Yeah.
Okay, item 6C is a recognition of Emergency Medical Services Week. Miss Esp. It's all of you all. Everybody can come on down. We love that.
That one's yours. Yep. They were voluntold.
Don't be shy. It's your Emergency Medical Services Week.
White.
Improving outcomes together.
You told me you come up. So look shame. We gotta laugh. Right? I told her she'd be behind me, so she'll show camera. Right there. Okay. Good morning, board. Andrea asked for the record. I have a proclamation for you. So, whereas emergency medical service personnel are called upon to help others through one of the most frightening times of their lives, whereas emergency medical services is a vital public service with personnel ready to provide life-saving care to the community 24 hours a day, 7 days a week, and whereas emergency medical service system consists of men and women in both the public and private sector, including emergency physicians, emergency nurses, emergency dispatchers, emergency medical technicians, paramedics, firefighters, educators, administrators, volunteers, and others throughout our healthcare system, who work together to ensure those in need receive the highest level of emergency service. And whereas the EMS commitment to patient care throughout Northern Nevada has been an integral factor in our safety and security. And whereas Washoe County is proud to have organized such organizations such as the Reno Fire Department, Sparks Fire Department, Truckee Meadows Fire Protection District, North Lake Tahoe Fire Protection District, Pyramid Lake Fire Rescue EMS, Remsa Health, Truckee Meadows Community College, and Technical Medical, operating throughout the region to ensure the highest quality of patient care and community support. And whereas the members of emergency medical services teams, whether career or volunteer, engage in thousands of hours of specialized training and continuing education to enhance their life-saving skills. And whereas it is appropriate to recognize the value and the accomplishments of emergency medical service providers by designating Emergency Medical Services Week. Now, therefore, it be resolved that Northern Nevada Public Health District Board of Health does recognize the week of May 17th to the 23rd, 2026 as Emergency Medical Services Week with the theme of improving outcomes together. And I would like just to acknowledge everyone that is standing behind me, that although we have our differences, we do come together to improve the outcomes of our patients.
Well, I think we can all stand and cheer for that. Okay, that concludes our items under the 6 proclamations item. We'll move now to consent items, and I'll ask my colleagues if anyone has anything on the consent item to pull. Doesn't look like it, so I'll seek a motion.
Move to approve.
Okay, I have a motion by Ms. Andriola, a second by Mr. Brown. They're duking it out today. Any additional questions or comments? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed? Motion carries unanimously. Okay. Item 8, this is our monthly update from REMSA. Mr. Duplantis, I see you're here and coming down. Welcome.
Good afternoon, Chairman Reese, members of the board. I'm Barry Duplantis, CEO, President of REMSA Health, for the record. First off, I'd like to publicly thank each and every one of you for serving on this board and for working to serve public health. You have a tough job because there's so much noise and distraction in our world and community today. Trust, ethics, and integrity are critical in public health matters. REMSA is a committed partner in our regional health system, and our mission is to provide 911 callers with high-quality emergency and non-emergency patient care and clinical transportation in a manner that is fiscally responsible and sustainable. Today, I'd like to provide you with an update of REMSA's ground franchise component of the operation. Ground services for REMSA represents about 45% of the organization's activity, and it employs actually the greatest number of people. It takes a lot of people to do emergency medical. REMSA utilizes a dynamic deployment model, which is designed to be responsive to the movement of people throughout our system. I understand today that you have been provided with a copy of REMSA's March 2026 report. So in further comment, in March, we saw a spike in demand for EMS services. We responded to 8,647 EMS calls, and we transported 5,737 patients to area hospitals. Our average response times for priority 1 calls were, in the case of City of Reno, 5 minutes and 30 seconds. In the case of Sparks, 6 minutes and 9 seconds. And Washoe County, 8 minutes and 37 seconds. With reference to responses based on our compliance zone map, REMSA continues to meet or beat franchise compliance for all priority 1 calls in Zone A, which includes the most populous parts of our region, and REMSA continues to meet its obligation for year-to-date compliance in zones B, C, and D. So what does that mean when we talk about compliance metrics? It means that REMSA is expected to be on scene in zones marked A, for example, 90% of the time in less than 8 minutes and 59 seconds. Mr. Driscoll asked me in one of our previous meetings about the impact of the 10%. I mean, because if there's a 90% criteria, what about the 10%? And I prepared a response and provided it to him for review. I'll review some of the points from that response now because it's kind of important to really explain the EMS protocol that we use in our community as it relates to the response metric. The 8 minutes and 59-second metric was popularized many years ago for high-priority EMS calls based on cardiac survival science promoted by the American Heart Association. This metric has been used for decades, quite candidly, and it's used because it's easy. It's easy to measure. Specific to P1 calls, REMSA is on scene first and only to the tune of 59% of the time. In those instances where fire is first, and I'll speak to that in just a second, REMSA is there within 3 minutes, 71% of the time, and under 5 minutes, 95% of the time. Co-response, which is very important to the way our system works, co-response by our fire agencies is used on all high-priority calls, things that we refer to as echo determinants, things such as choking, drowning, electrocution, cardiac arrest, major trauma. In these particular types of calls, everyone goes. I mean, it's all wheels are rolling immediately. Aside from that, each local fire agency responds a little differently based on the EMD of the call. In the case of the city of Reno, they tend to roll and then cancel en route. In the case of Truckee Meadows Fire Protection District, because we coordinate their EMD in conjunction with fire dispatch on our platform at REMSA, we are able to provide them with information as to the acuity of the call and the need to roll or not. And in the case of sparks, we use what we refer to in our industry, or at least in our business, as Code 76, which means that the personnel go down to the vehicle and they wait for the EMD determinant to determine should they go, should they not go. But notwithstanding that, if it's an echo determinant, all wheels are rolling right away. There's no delay. So I just wanted to make sure that we understand how the system works in terms of responding to calls. So all calls receive a response. Now, given that I told you about that 8 minute and 59 second, quality of clinical care is important. Studies and current professional research show that the quality of care actually matters more than speed. In Northern Nevada, our system of patient care begins with the call triage process, which is handled by clinically trained technicians who begin life-saving care such as CPR, tourniquet guidance, childbirthing, coaching, clinical decision-making, assignment of appropriate resources, including integrated health solutions. In all cases, this is an important point, in all cases, patients receive care before ambulances or fire resources arrive on scene. Clinically trained EMS triage and call dispatching is the secret reason why REMSA has been one of the most successful EMS operations in the nation. A few years ago, Truckee Meadows asked REMSA to provide fire dispatch services to the agency. REMSA currently provides effective, efficient, and informative dispatch of fire apparatus for Truckee Meadows. And today, we're actually actively working with our fire partners to expand this practice of consolidating fire and EMS dispatch to improve the utilization of fire resources and essentially save resources for higher acuity calls, and in particular for fires. Dispatching the closest appropriate ambulance is absolutely important. But the thing to keep in mind is that keyword appropriate. And the reason why is because what we find is that EMS is used as the safety net for healthcare in our region and in many, many other regions. And for that reason, we have ALS resources and we have BLS resources. We've seen a surge in the demand for BLS calls in recent months, and I really think that's going to continue to rise. And it's important that we essentially reserve or preserve our fire resources for those highest acuity calls, and that we don't consume their skills on a stub toe, for example. RIMSA is a not-for-profit, a 501c3 organization, and only charges for ambulance services when patients are taken to area hospitals. Now, you probably recall that you actually determined what our average bill rate is. Our average invoice that we're allowed at this point is $2,261.13. Now, I point that out to you because Medicare represents 44% of the patients that we care for. And although you give us an average bill rate of $2,000, et cetera, our average collection on a Medicare is $440. In the case of Medicaid, which represents 31% of the patients we care for, our average reimbursement is $245. In the case of private insurance, and keep in mind, we talk about an average bill rate that, is governed, controlled, if you will. Private insurance, which represents 20% of our patient mix, only pay $1,700 on average. We have to really claw payments. And then we have a fair amount of uninsured. 5% of our patient mix is uninsured, and our average collection on the uninsured group is $48. So I really want to kind of give you that context so that it all kind of fits together, because the one thing that I think that we've come to realize as we've had many conversations over recent months is how complex the EMS world is and what it takes to make it work and how the public is consuming EMS. With regard to RIMSA's community partnership, RIMSA believes strongly in being a collaborative and cooperative partner in regional healthcare. I want to give you just a couple of examples of that. And this is one that just kind of harkens because I saw it in the news, which made me think there's confusion. RIMSA replaces medical supplies used by fire agencies or reimburses fire agencies for the cost of such supplies used in the case of co-responses. Absolute fact. That's also it's stated in our franchise agreement that we will do that. Not many people are aware that RIMSA picks up that cost. The other point that I want to just draw attention to, because it is significant, is last year, as I think I mentioned, we transported 61,290 patients in 2025. And of that, we incurred, because not everybody needs a ride to the hospital. A third of the time, a ride to the hospital is unwarranted, but we provide care on scene. The value of that care on scene, $7.7 million. That's a cost of doing business for RIMSA. The other component of uncompensated care is when we actually transport. That's when we do provide the care and transport, and that's $1.9 million. Collectively or additively, if you put those two together, it's $9.6 million of care that the organization provides to the community as a cost of doing business. Speaking about our survey results, for the month of March, we had a score of 92.95, which was consistent with the same period in the prior year. Our highest scores were the degree to which the medics took the problem seriously and the skill of the driver driving the ambulance. These ratings were higher than the national average. Our goal is to provide our community with timely, compassionate, and high-quality emergency pre-hospital care. I want to speak just a moment for fire regionalization. We are wholeheartedly supportive of the fire regionalization study that is being done. We were asked to provide and assist with data that was needed for the study, because as I think you've come to know, RIMSA has an enormous amount of data. We provided the data that we were asked for, and we look forward to the results of the study later this year. I'm hearing September timeframe with presentation to the governments in the October-November timeframe for adoption, kind of like in the December timeframe. So that's the latest I've heard on that. And then lastly, I'm happy to report to you that our Meet and Confer meeting that was referred to in the franchise discussion we had previously is scheduled for May the 4th, 2 p.m., I believe is the time. And we're looking forward to those meetings, which I know we're going to discuss a little further in item number 10, for which Dr. Kingsley is going to present. All that being said, I wanted to provide you with a bit of detail and context to some of the parts of the operation that sometimes just kind of happens behind stage, and we don't recognize what it really involves. I'm happy to address any questions that you might have for me with regard to what I presented to you today.
Mr. Duplantis, thank you for the excellent presentation. Let me see what my colleagues have questions about today. Mr. Anderson's up first.
Thank you for the presentation, Mr. Duplantis. Did have a couple questions, concern. One of them in regard to the response times, and you were talking about the dynamic, I believe it's dynamic dispatch, how you move them around depending on the algorithms that show where the need is. My concern is that if you're using a system like that, you have light to medium duty vehicles with 2 people that are typically sitting in the vehicle. And yet, for the city of Sparks, a recent study that I showed or was shown was 44% of the time our heavy duty fire apparatus with 3 firefighters comes from a fire station that they could be cleaning, working on equipment, cooking dinner, and they're able to respond more quickly than your ambulance, 44% of the time. I just want to make that comment and ask the question, how can that be if you're more nimble and your equipment is operating in that dynamic status? How is it that we can respond 44% of the time on a heavy fire apparatus, which happens to cost $1.5 million in comparison to an ambulance? How does that happen?
Well, first off, I'd have to say I'd have to know what your data is. Because without knowing your data, it'd be hard to compare. There's one example, in fact, that I had a conversation on just this morning. It came up in a matter of it was part of a discussion that we had. You had an incident, for example, at one of your fitness centers where there was a shooting, or at least there was threatened to be a shooting. The person called, he was mentally upset, and he was going to go in the sports center and shoot people. Well, fortunately, that did not happen, but we happened to be in that very parking lot. That's why I mentioned that. We have ambulances placed. Sometimes we're going to be the closest, sometimes we're not. It just depends on where the incident is. So I bring it up because that was just a matter of chance. We posted in that parking lot of that particular health center when that particular incident happened, and your police responded very quickly, and and there was gunfire and that kind of stuff that took place. So I'd have to know your database to really reconcile, if you will.
Okay, I'll make sure I work with our team to be able to get that for you, to make sure that we're comparing apples to apples. But again, it's just, I can't wrap my head around how that could happen, that this big lumbering fire apparatus is able to get there almost half as often before your units show up. The second question I had, or again, whether you want to put it as a question or a concern, is you were talking about how cost effective the services are that are being provided by REMSA. It just came up with us at the City of Sparks. Our employees were submitting complaints to our insurance company because they were receiving bills from REMSA that were over and above what the insurance covered. Once we looked into it, our human resources department found out that REMSA was overcharging the norm, and that's why our insurance company wouldn't pay the full amount for our employees. So these are our very own employees at the City of Sparks, which we happen to have what I would call a Cadillac program, can't even cover the cost of your service because the services are so highly priced.
Once again, I have to, your statement is a complex one, because when it comes to ambulance coverage in insurance policies, They vary very significantly. So you can have, in fact, a Cadillac or a Rolls-Royce policy, if you want to call it even more elevated than that. And ambulance coverage in all of these policies vary significantly because it's kind of how the insurance companies manage the premium costs. So I'd have to look at that particular situation because I really would want to understand the details. Because without the details and the facts, it's hard for me to reconcile that. But I do know from our billing office that ambulance coverage is all over the map when it comes to who covers what. And it just depends on the policy within the company, because it's not like you could simply say, well, Cigna's the best. Well, because there are many, many, many versions of Cigna's insurance policy, and the ambulance coverage will vary, from policy to policy.
And I understand that. And yes, just like any other services, they can vary a great deal in what insurance companies want to cover. Again, my concern is that they're talking about the average cost of an ambulance ride, if you will, that REMSA was significantly higher than that average. So I'll work with my team to contact you and let them explain what we're seeing. Thank you.
Yeah, please direct it directly to me, though, because I want to make sure that we get you a timely response.
Thank you.
Mr. Anderson, thank you so much for your comments. I'll also offer that I'm happy because we are the District Board of Health. We do oversee the franchise. That if you have some data sets that provide the answers or the issue that you're looking at, we'd like to know them here too, right? It's not just enough for you to work with REMSA directly, but if your equipment is arriving first more often, I think you said 40%, I'd like to know that, right? And then if there's cost issues, I'd like to know that, because that's not consistent with what I understand we have evaluated, and therefore I would like to be able to look at the data set. I agree with Mr. Duplantis that we've got to compare apples to apples, and I'm not sure that in this particular form we can easily do that. So Dr. Kingsley, if you'll coordinate some effort in that regard and make sure that we are keeping track of the issues as they arise, we'll get to the bottom of it. Any other questions from the body? Mr. Duplantis, I have a couple. So the first thing I wanted to talk about was, and I'm focusing on the report. There may be other questions that I have in our other agenda items, but I wanted to, we had this proclamation about this being Emergency Medical Service Week, and I wanted to acknowledge a couple of things I saw in the comments. Some of the comments roll from month to month, and then they end up being there again. But a couple of them that I noticed that I really wanted to point out. This one really got me, which it says, "You kept me from dying," and I was very happy about that. Right? That was a very nice comment that someone wrote in. There was another comment that someone says, "The care I received was empathetic and professional. They eased my concerns, making me relieved that I was getting top-notch services." And ultimately, the reason why I'm grateful for you to provide these in this comment format is because I cannot be there. I certainly don't know what your folks are experiencing. Occasionally there's a bad comment, and that happens. I didn't see any in here this time, but what I will say is I'm grateful to see these comments, because that is what our expectation is, and certainly Mr. Anderson's expectation, or any of us on this board, is that those are the kind of comments that provide an insight into what happens with the delivery service that you've talked about. The second thing I wanted to ask about was dispatch. So I've had the opportunity to meet with a number of our different firefighting groups, individual members, and there was a conversation which I'm not as well aware of or well versed in. I wonder if you might shed some light on, and it has to do with the way in which the calls are received by dispatch and then characterized as different levels of service. As I understand it, there's everything from 1 through 5. What are the service levels?
I can't comment about the specific levels, but what you do say is correct. Because I don't know that level of detail. What you do say is correct in that the calls come into primary answering points, and then at that point they're saying police, fire, medical. And what's important to remember is that when it comes to the call handling at that point, when the person says fire or medical, they tend to be intertwined. And for that reason, I and the fire chiefs talk periodically because, I mean, we have a common goal. And as I indicated about the echo determinants, those are calls that we pick up very quickly. If it's a choking, we know that, wheels are rolling before we finish the EMD. And that gets triaged as, for example, like you just said, that would be an absolute priority one. All wheels are rolling right away, get first hands on patient. And then, yes, as we go down the EMD process, it then trickles down into lower levels, all the way down to, it's a behavioral issue where somebody, and this actually is a person that does this in the community. We finally got him to stop calling 911 because he got anxious. Every time he would get anxious, he would call 911, needed help, and we would respond. So with integrated health, we were able to essentially to work him out of the system. And so that instead of calling 911, call us in our office. We'll walk you through, this anxiety issue. So yes, the calls do get triaged to where, as I said, it's from all wheels rolling immediately, all the way down, let's say next level would be like ALS, advanced life-saving support. And then beneath that would be like BLS, where the patient's essentially stable, not likely to die, but need help, all the way down to sometimes we send an Uber. That is one of the things we do. If someone needs to go to urgent care, they don't have a ride, we'll send them an Uber, pick them up and take them where they need to go.
Well, and I think you've shed some light on it. I want to still ask the question, though, and it has to do with sort of an anecdotal experience where there is some concern raised by firefighters in my jurisdiction that sometimes they arrive at the call and they have been dispatched and it's been mischaracterized in terms of what level it really should have been, a 1, a 2, a 3. And so I'm not saying that I have a data point to share with you, but I'm trying to understand how frequently is that happening where our firefighters and anything arrive at a call because they've been called to do so, but they arrive there and you find that they have been summoned unnecessarily, right? And the concern is that because of the control of the dispatch system, that you were able to dispatch them, but maybe you didn't need to, but you characterize it in a certain way so that the dispatch caused the fire folks to respond. Does that happen, or is that something we're trying to work through? I know it has to do also with the different kinds of communication equipment that are being used, but what I'm trying to say to you is if a frustration comes from my firefighters that they believe they're being dispatched unnecessarily to a call, I don't want that to happen. And similarly, I don't want them to not be dispatched, and then we find out it's a life-saving issue, right? So how do we work through that from the dispatch side? Because that's what I didn't hear in the answer.
It can happen. It can. What I would ask is that when those incidents do happen, we need to know about them so that we can learn from them.
And you do like after action?
Yes. Yes. And in fact, we actually meet 9 o'clock every morning we do an after action review every single morning on campus where we look at calls of the previous day and what can we do better. I mean, so an after action review is a normal part of our process. So if there are instances, I absolutely need to know about them because, yes, it can happen. And in part, the reason why it can happen is that if you take, for example, in your case with the City of Reno is operating on a different platform than what REMSA is. I mean, so there are some differences there. And obviously, we think that the Hexagon or Octave, whatever it's called these days, we think that it would offer a solution. But we do have a plan B. I know Commissioner Andriola has asked in the past, what's the plan B if we are not able to go live with the Hexagon so that we can master this? Chief Edwards and I have had plenty of discussion. J.W. Hodge at City of Reno and I have had discussion as well as Chief Cochran. We want to solve this problem of getting everybody one way or another. We need to be on the same platform to minimize these types of issues.
Well, I certainly think that communication system, and our hope is that it's coming soon, we've been saying that for a while now, is part of the solution. Let me ask, as to the after action calls that you do each morning, who are part of those? It's you, your medical director, your chief of tell me who's in there.
It's our dispatch leaders. It's our ground operators, the managers and supervisors that physically work in the field throughout the day, overseeing the crews. And the That's largely the people, and then of course, folks like myself. I pop into those meetings periodically. Our chief operating officer, Adam Hines, is frequently, in fact, typically, he's the one that chairs the meeting. But I also have a couple of my data analysts in that meeting as well, because we're always looking at how are we doing with regard to, are we putting ambulances in the right parts of town to get effective coverage in the community? Because we do have to make adjustments. And then we also look at scheduling. So, the folks that we have that are responsible for scheduling are in those meetings as well, because we're looking at if someone is sick, called out an issue, then we have to find another partner for that person in order to fill the shift. So every morning, 9 o'clock, is essentially the different disciplines of the operations team that it takes to get the job done.
And if one of our engine companies or crews at the city of Reno has had a bad experience the day prior, let's just say, how can they transmit or communicate that information to this clutch of people who are gathering?
First off, get it to myself or to Adam Hines, and we will make sure that it becomes an item that is resolved in the after-action review meeting.
Okay, thank you so much. I appreciate that.
I might also ask on that very topic, I'm guessing about 6 months ago, there was a question that, had a similar question came up with the leader of the 731 labor union group, and because he had raised a similar kind of concern, and and I asked, just as I'm asking now, get me the data. Get me the data so that I can work it. So it's not the first time this question has been on our minds, of one for which we'd like to solve, because the last thing any of us want to do is misassign and misallocate resources to our community, because we've got to really be very judicious about what we use. And as you mentioned, a $1 to $1.5 million fire apparatus responding on a stub toe is just not what we want to do.
Yeah, I think we all agree on that. I'm going to sort of put a note in my tickler to make sure that we circle back with you. I know the folks at 731 pay very close attention to these meetings and are here today. And so it sounds like an ongoing issue for which we'll need some additional conversation. But thank you for that. You've given me a lot to chew on. The last question I had, and then I'll see if anyone has any, is I noticed this EMS Explorer program. What is that? You've launched that just recently?
Yes, and actually, I am not the right person to comment on that. I mean,
I'll have
Alexia.
someone circle back with me because it looks interesting. I sort of fundamentally understand Explorer programs in other agencies, and I'd like to know a little bit more. But in the presentation materials, it was a little blurry for my end, and I couldn't get into the QR code. And so I would like to know about it because it sounds like an interesting program.
Well,
Thank you so much. Let me see if there are any other questions from the board. Okay, we don't have any. Oh, Dr. Kingsley, you've got some comments.
Thank you. Just wanted to make a comment that with a subtle change in the presentation and the monthly report that is presented, so under federal obligations, we were required to be accessible to our public and our community. And so in order to do that, to meet that compliance, we are providing a link to that report currently right now. So that's where it changed. Just wanted you to be aware of that. So when you click on that link, it does open it up there at REMS's page. And so this is to meeting our, actually this month's, we are meeting compliance with our accessibility. So I just wanted to acknowledge that, the change in that report of how you receive it.
No
Thank you.
problem. Thank you. That must be why I can't read it quite as well as I have in the past. But thank you so much. I'll look for a motion for acceptance. Mr. Driscoll on the first, Mr. Brown on the second. Any other questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed? Motion carries unanimously. Okay, that brings us to item 9. Item 9 is a hearing. Unless there are any questions from the board, I'll look for a motion. Okay, I have a motion by Mr. Brown, a second by Mr. Driscoll. Any other questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed? Motion carries unanimously. 9B is a similar matter, but with Air Pollution Quality Control Hearing Board. Any questions from this body? Hearing none, I'll seek a motion. Ms. Andrews on the first, Mr. Driscoll on the second. Any other questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed? Motion carries unanimously. Okay, item 10 is presentation and identity or identified items with Northern Nevada Public Health to discuss the REMSA Health EMS franchise agreement. I believe, if I'm not mistaken, Madam Clerk, we have public comment on this item.
Yes, we have Mark Thayer, followed by Patrick Walsh.
Mark, welcome and good afternoon. Thanks for being here. Mark is the president of the Truckee Meadows Fire Protection District Union, and it's good to see you.
Absolutely. President 2487 IFF Truckee Meadows Firefighters. I'm here today mostly to speak about the REMSA contract and the upcoming meet and confer meeting that you have with REMSA. Before I do that, I'd like to start by recognizing and congratulating the flight nurses and paramedics of REMSA's Care Flight Division, who just recently voted to unionize under the Transport Workers Union. This is a big, bold step, giving them a voice in their own organization, specifically on their own safety, among other topics. And I'm certain safety will be a primary topic when they come to collective bargaining under that new union. The members of IFF Local 2047 stand with you, the new members of the Care Flight Division's union. As mentioned, I'm also here to address the Northern Nevada Public Health Workshop's list of concerns regarding the extended REMSA contract. The first of these is the REMSA board does not adequately include public fire agencies that act as primary co-responders. As was mentioned previously in the Truckee Meadows Fire Protection District, we are on scene predominantly more frequently and earlier than REMSA, as our neighboring agencies are. In these cases, we are providing that initial care to that patient to stabilize them, prepare them for transport. We share that a large portion of that workload in the field, yet we lack any meaningful input in the system governance. That disconnect impacts accountability and system design. Representation should reflect the reality of how EMS is delivered in this region. Secondly, priority 2 calls for service make up a significant portion of demand and should carry performance accountability. While on the surface they seem immediately non-life-threatening, delays can still affect patient care and system efficiency. There should be defined response standards for priority 1s, priority 2s, in addition to the ones that are defined as critical life hazards. As an anecdotal piece of information, I went on a call a couple months ago that was not prioritized at all. It was a ground level fall with a headlock, turned out to be cardiac arrest. So that's, once again, this is anecdotal, one little bit of information, but the system isn't perfect. We do need to have accountability for our priority 2s as well as our priority 1s. And just as a point of clarification, any subcontractor for REMSA would fall underneath those same requirements. So this is not something that I'm suggesting that we're not willing to fulfill ourselves. Finally, if REMSA and the Board of Health are concerned with community safety and positive patient outcomes, they need to reconsider the closest unit response. Fire and ambulance personnel can do a lot to stabilize a patient, but in most critical priority 1 cases, a positive patient outcome requires hospital-based interventions such as surgery, labs, and imaging. In other words, faster arrival to that patient is faster delivery to definitive care. That's really all I have for you today, and I kept it under 3 minutes, so you got 20 seconds for questions.
Well, we don't generally ask questions, but I'll ask.
Certainly.
Tell me the name of the Care Flight Union. I tried to write it down, but did you?
Oh, it's the Transport Workers Union. It was announced on their website yesterday.
TWU? Or?
Transport Workers Union, yes.
Okay, thank you so much.
You're very welcome. Thank you.
Madam Clerk.
Patrick Walsh.
Patrick, hello.
Sorry about that. Good afternoon. For the record, Patrick Walsh. At the center of everything being discussed, being franchise agreements, response metrics, compliance standards, there's one principle that must guide every decision: getting the right help to the patient as fast as possible. Right now, our system does not consistently achieve that.
We continue to operate within a structure where jurisdictional boundaries and franchise models take priority over what should be the standard of care, sending the closest, most appropriate available unit regardless of whether that unit is fire-based EMS or private ambulance provider. That gap has real consequences. When the closest resource isn't dispatched, patient contact is delayed, and in emergency medicine, minutes matter. The materials listed in the Northern Nevada Public Health Workshop highlight important concerns: a lack of clear compliance incentives and meaningful penalties, gaps in response time definitions and interfacility transfer standards, missing transparency in data access, and unclear or inconsistent expectations around system performance. These are all symptoms of a larger issue. We have not firmly established closest unit response as a non-negotiable system standard. If we are serious about improving outcomes and accountability, then the franchise agreement must do more than outline participation. It must enforce performance. That means clearly defining closest unit response requirements across all providers, establishing measurable benchmarks tied to real-world deployment, creating transparent reporting so all stakeholders can evaluate performance, and implementing enforceable consequences when the system fails to meet those standards. Additionally, we should ensure that reimbursement structures and co-response expectations support cooperation, not competition, between agencies. The system should reward doing what's best for the patient, not what's best for a boundary line. Thank you.
Patrick, and I didn't catch the agency you were with. I'm so sorry.
I am a member of Local 2047 and a 19-year paramedic, 13 of which has been in Washoe County.
Fabulous. Thank you so much.
Thank you.
Appreciate you. Madam Clerk, is that all we have for public comment on this item?
There is no additional comment.
Okay, thank you. Dr. Kingsley, welcome and come forward. I'll just share for the board. I asked Dr. Kingsley to provide us with this update today, and I'll just say a couple things to set the table as we're preparing the presentation item. So the board directed Northern Nevada Public Health in January to meet and confer with REMSA Health within 6 months, and that work is underway, certainly as directed. Part of that direction was to include feedback from stakeholders, and so the district health officer, through his staff, requested feedback from all jurisdictions by March 17th. I believe you'll identify this hopefully in your presentation, but I'll say the workshops that were scheduled for skilled nursing facilities and one-on-one had no attendance from those facilities, unfortunately. 2 jurisdictions did respond and provide written feedback, which was taken into consideration and is attached in today's packet. The result is the 19 identified items, which I have separated out as spanning governments, operational performance, and contract language. And today's presentation is designed to be informational. The confer process does not require board action today, but is structured as a good faith dialogue process between Northern Nevada Public Health, REMSA, with board oversight. So with that, Dr. Kingsley, the floor is yours.
Thank you. Dr. Chad Kingsley for the record. Today, just bringing forward just the information that was summarized over since the January District Board of Health meeting. So just an update to you today for the directive to meet and confer with REMSA. So we've synthesized our inputs from both the District Board of Health concerns raised during the January 2026 review, as well as our system partner concerns on March 18th and April 1st, and our workshops, as well as other contributions between 2024 to 2025, the dates of those which were provided in the attachments. So overall, timelines and dates: sustained engagement for franchise discussions. So post-July to July 24 franchise renewal contractual dates. Multiple forums from 2024 through 2025, which include JAC meetings, regular cadence, and update up to the 2026 MSAB incorporation, and in coordination with the District Board of Health, county and city managers and attorneys, and Northern Nevada Public Health and REMSA coordination meetings. Then post-January 2026 approval and amended franchise forums. Those forums included the skilled nursing on February 8th, 2026 and February 12th, 2026. As mentioned, did not have attendance from those, but was widely broadcasted to them. The first workshop for our stakeholders was held on March 1st, March 18th, 2026, and the second on April 1st, 2026. Those items discussed in there, as well as the video, but it is available, but those items discussed were documented and provided here within the attachments. So here, Northern Nevada Public Health and REMSA now on It was noted on May 4th. It was May 3rd here, just confirming May 4th, correct? So the time is wrong there. So May 4th.
May the 4th be with you.
Yes, may the 4th be with you at 2026, and we will meet to confer. This will be the first of those meetings, and then follow up to any of those, but items summarized and provided to the District Board of Health will be taken to REMSA to confer over. And the intent that we see from that 6-month is identify immediate changes to incorporate into the amended and restated franchise agreement on July 1st. Contractual performance and governance. So we collect a clear year of data on those new performance metrics there. And then identify and plan for future possible franchise amendment using annual or in the 4th-year process to defined in the contract. So we will return to the District Board of Health in May or June with 2026 from the results of those meet and confer.
Okay, Dr. Kingsley, thank you for the brief report. I'll bring it back now to the board. I do have some questions, and so I'll reserve those till after, but I'll look and see who would like to start us off. No one on this side? Let me say a couple of things. First of all, I did hear a concern today raised by 2487 about the inclusion of firefighters in these processes. And so this is sort of both a apology from me to those folks who find themselves in that position, which is to say that when I got the green light, as I understood it, from our fire chiefs, I, of course, believed that they were representing the interests of their members. And so I think that's sort of some level of naivete on my part, in part because I do not know, especially the emergency medical dispatch side of the house or the ambulance franchise firefighting model that we've created in this region, as well as any of these people do. So I want to know what we can do. Is that something that's and maybe Ms. Esp would say it's through the JIC or the MSAB. There are all these organizations, and the alphabet soup of it can be confusing for those of us who sit on this dais. But how do we make sure that the people who are responding to the calls have a role in the system that we are creating? Because, if you're a firefighter and you're responding to 15 calls a day for medical services, but you're finding yourself frustrated by the service system that we've created, but no outlet to voice those frustrations, how have we built a better mousetrap if that's the case?
Thank you. In response to that, so it's complex, but as simple it down is that the regional governance of the REMSA board that continues today is one point of area that has been addressed and looked towards that fire representation on the REMSA board. Other areas that it gets into representation of is established in 2014 MSAB, which is a model moving towards where representation can be increased there. But yes, also the Joint Advisory Committee is where we meet with EMS chiefs and we review specific cases as well as performance. And a lot of our performance metrics in our current amendment was brought forward in those meetings. There's always the opportunity to improve that inclusion. I also say that we are also somewhat divided in the sense that there are components that require us that they have to report to the state, where we do not have authority, and local authority that we've created through the ILA. So some, if it is an individual, say a case or a sentinel event that occurred and needs to be follow-up debriefed, how can we improve? That lies with the state many times. We do not have the authority there, but we do try to incorporate that in. But then how does that information from the state then come in and be integrated into our overall system? So we do have various challenges as our point there, but yes, the recognition and is part of that to bring forward how do we better include fire within the participation of our
Well, and
EMS
you can
system.
see I have a consistent theme today. I asked Mr. Duplantis sort of a similar and related question about how they get the information, because what I don't want to have happen is someone like Mr. Walsh, who's come here today and taken the time out of his day to air a concern, and then just have us go back to our lives and say, okay, we heard it here in this body, in this room, but then we haven't done anything with it. So I will be asking about that as we move forward in this process. You and I have talked about the fact that this is an iterative process. Today was not the opportunity to do every single thing that we wanted to talk about. A lot of the material in the presentation was very good and very comprehensive, and I encourage everyone to read it. We will have several months here still as we move forward to make changes, adjustments. Maybe we're going to add something back in that was removed. Maybe we're going to fix something that could be made better. And those are the areas where communication has to be improved from my perspective. That's both to Mr. Duplantis's concerns, which he gave me some good feedback today. But what we want to make sure happens is that the people who are the most affected by it, and you said chiefs, right? They get to do the chief thing. Chiefs start to get into that higher level of reaction, and I'm looking for what happens to people in the rigs. We get oftentimes very far away from that the further people get in career advancement, and so I want to make sure that people who are responding to those calls, because they're the ones who are frustrated when they go to a call for service and it's been misclassified or misidentified, or they get there and they say, well, we've got to take your higher level skilled paramedic onto our ambulance, leaving our rig unattended, then you're transferring all these liabilities around. I don't like to hear those things, but I don't always know how to fix them. And so from my perspective, I have you, and certainly you're like the tip of the spear to go to the parties, but there has to be a way for those people to plug into the system to build the better mousetrap. And I think Ms. Esp is someone who has been very consistent with me to be able to let me voice my frustrations, but those have to be then translated into action. So, and what we can measure and quantify, we can change, right? It's not, the anecdotal stuff is helpful because it makes some more sense to me, a non-person in this area. But the important part is that you and Ms. Esp and Mr. Duplantis and each of the fire agencies are working to make these changes and adjustments. Make sense? Thank you. Yeah, you ready?
I am.
Jump in. I am done. I talk a lot.
I wanted to follow up on a couple things. Thanks for putting this together, and more importantly, thanks for doing the workshops. And thanks for actually dedicating the time to collect all this information, and it took a lot of time. But I'm not clear, what I'm not clear on is where the priority is. There's a lot of information, both in capturing and summarizing various members and their items that were shared at the January meeting, and then through the March 18th and April 1st, the 19 items that were captured. And again, thanks to everyone on the staff who put in the time and capturing all of that data. But it's not clear on where these priorities lie, number one. Number two, it was just echoed by the chair, and it was echoed throughout a lot of different comments by a lot of different folks about the JAC. And even though the MSAP is moving, the fact is it was removed. And that is not clear. And we keep on talking about it, but I'm not clear on how that gets integrated, and then how, more importantly, there is not only the voice the chair spoke about and some of the public commenters as well, but how they're actually at the table. And so I just appreciate the May 4th is around the corner, and I will be saying may the force be with you as well. But it's not clear. There's not a plan. There's a plan to talk. Is there? And so I'm going to make sure I'm understanding. The entire packet of information that summarizes everything that came from both workshops and the January, will that then be discussed with REMSA on the changes? So everything that's in here will be discussed?
That's what we're taking to REMSA, yes.
Okay. And so will the JAC also be discussed in terms of how that works? In terms of what we just spoke about, not to regurgitate all that again?
It's on there to be discussed with REMSA, yes.
Okay, and what is the responsibility of REMSA to accept this information? In other words, what I'm really getting at is a little bit rhetorical, because the contract is only as both parties and meet and confer. So there isn't really a responsibility for REMSA to agree to it, although we value the fact that it's in good faith. but there isn't anything that actually holds anyone responsible at this point in terms of the two parties to that. And so May 4th, then we'll have the meeting, and then you're going to be bringing back then the items that were agreed upon and then the items that weren't agreed upon, because none of that plan, I'm just making a leap that that's what, is that the plan then?
Correct, yes. Yeah. We will take those and take those items to REMSA and discuss those items and bring back to the board those items that were either integrated and those ones that were not integrated and the why.
And when will that come back?
Either in May or depending if it takes longer for those contract negotiations, not negotiations, sorry, just that discussion to meet and confer. Herb will be there, so soonest would be May, next District Board of Health meeting, or June. We would
When is the 6 months?
hope. August would be the August meeting, District Board of Health August meeting,
August or September?
I believe.
I
Yes,
can't remember if it was September or August. So in other words, if
It's August.
it's August, okay, great. So if you are meeting on May and then it comes back in June, and then if there is a high propensity of some items that seem to have a higher weight of consideration, then what happens? Do you go back and meet and confer again, or how does that process fold out?
I would believe at that time it would be board's discretion, and so we need direction from the board on those items if they needed to be prioritized, or whatever it is not incorporated, it doesn't mean it's no longer, it's off the table. It would be incorporated and prioritized that beginning July 1st, what is prioritized and what is discussed for a possible amendment during that first year process as defined in the agreement.
So I think at one of the meetings, I watched the hour and 58 minutes or 4 hours. I can't remember. It might have been 4 hours. I don't know. I lose track of time. It was a long meeting I watched. And then I went to the April 1st meeting, and I thought that there was going to be at least in this particular meeting, before the meet and confer, in these tables that were presented as you guys were doing it live, that there was going to be additional columns of how you, meaning Northern Nevada Public Health, felt were priorities, and I don't see any indication of what that is. So that's where I'm a little bit confused on the plan.
Okay.
Is there, I
They were
know
not
that was
prioritized, no.
discussed.
It was
I
brought
re-
forward on those points, and it was, we would need to do further prioritization with our stakeholders on prioritizing these items. But we wanted to, due to the expediency of the 6 months, to be able to provide and be able to meet with
Okay.
REMS in time so that we could come back and provide that information.
Well, I think it would be helpful to understand, even if I were REMSA, I'd certainly want to understand. I know a lot was, shared, but in both the viewing of the workshop and then attending the second workshop, it was clear that there seemed to be some areas that seemed to have a higher priority. I mean, all of it was important, and I'm not suggesting one isn't more. But if you're going in to meet and confer, I would think a plan that would be helpful would be able to say, this is really important. For whatever the reason. And so I was looking for that and just didn't see it. So the plan seems to be lacking, at least from my perspective, a clear direction.
Okay.
But, and I thought that was clear in both of those. So I just wanted to bring that up because I think we're trying to be fair to everyone. And REMSA certainly has been a good partner. And I'm very hopeful that their commitment to the community, which is longstanding, that the meet and confer is more than just, this is what we'd like to consider, but the priorities, especially with the JAC going back. And I'm not going to pick the ones that I'd like to actually prioritize. It's not fair for me to do that.
Well, Ms. Andriola,
You know?
that's ultimately why
Yeah.
I made the decision not to change the structure of the report to you, because every entity had priorities that were different. So rather than say, here are our priorities, which we wouldn't have had the ability to opine on, we just said, all of these are priorities. Go forth and in good
Okay.
conscience take them up. I think people understand that some things are bigger things than others, right?
Okay.
But you and I could disagree about what those are. So rather than like rank them or say these two are really important, we wanted all of them to come.
No, I appreciate it. I think all of them should come, for the record.
Yeah.
I wasn't suggesting they all shouldn't, but it was discussed. So I was just following up what was discussed in the workshop that both I watched and attended. So I was just following up from that perspective. But
Thank you so
Thank you.
much. Yeah. I wanted to go over something too, in some part to have a conversation with you, Dr. Kingsley, about the board's authority over the agreement as we move forward. So I want to make sure that my colleagues understand, and Mr. Kaplan might jump in here if needs to, but the board, of course, remains meaningfully engaged and has oversight at every stage of this agreement. There's annual compliance reviews, a mandatory comprehensive review before March of 2030, and the ability to terminate for cause on all remain fully available. Is that correct?
Excuse me, Herb Kaplan for the record. Yes, that is correct.
Thank you so much. And then over the 5-year term of the agreement, the board will have structured review touch points every single year. So in years 2 and 3 and 4, an annual compliance review is contemplated by September 30th of each year. And in year 3, there's a market study that is due by December 2028, which benchmarks REMSA's performance and cost against other EMS systems, which was the design check-in period. And so I want to make sure that the board understands that there are comprehensive reviews built into the agreement. On top of that, after the comprehensive review, not later than March 31st of 2030, the district can give REMSA health notice of non-renewal at that time, and the parties continue under the terms of the agreement or until 2031. And so there are opportunities for us to have meaningful oversight. We aren't locking ourselves into something that we can't get out of. I want to share also for those who were not on the board at the time that this decision to structure this contract in this way was after a period of time in which we really had historically had much longer contract periods. And I think what we learned through this process is longer contract periods do not inure to the benefit of transformative change. And so we wanted to make sure that, I think, Dr. Kingsley, thankfully, due to your leadership, there was a lot of sort of pushback against the old model. And so I think that you brought that experience from Southern Nevada, and it was gratefully received here, because I think, and I think Ms. Esp too is added to this conversation, those review periods are designed for us to continue to have control over it, so that when we do see things that are not working, they can be reasonably brought into the conversation. I don't think that REMSA has ever been the kind of partner who says it's our way or the highway. I know some people have felt about that historically. Maybe that was the case, but not under this current administration. And certainly given their participation in this process, they have shown me the confidence that they are participants willingly in the process. So I'm very grateful for it. I think I'll continue to stand by what I've said earlier, which is this contract maybe is not perfect and there are still things to work out. But I have never believed that in contracting that perfect should be the enemy of good. We all want the same thing, which is good patient health care outcomes. We want people to save lives to be saved when it's necessary. And so that is, I think, what we're working on. The fact that the REMSA agreement was amended in the 40 years of the agreement suggests that when there are issues that arise, they will be reasonably and timely dealt with, regardless of what any of the things that lawyers try to design to protect our consumers, right? And so I can't remember what the number was, and maybe Mr. Kaplan would tell me, but it was something like 65 amendments over the course of a 40-year period. Now, some of those became side agreements and memorandums of understanding, but in some way, it was an evolving document. This document is not intended to be inflexible. And I want to call out, Dr. Kingsley, your role in that, because I'm good at contracts, right? I'm a lawyer in my professional life, but you are very good in having the larger vision for what we're trying to accomplish, which is good patient outcomes. And so for my part, I'll thank you for that, and then see if there are any other questions at this time. None? Okay, thank you so much. And I'm not sure, Madam Clerk, was this for, oh no, this was presentation only. Thank you so much. Okay, Dr. Kingsley, don't go anywhere because you're on the hot seat. Welcome to Nevada, where we get to review you annually in a public meeting. I will say, as we tee this up, first of all, this is a unique thing that happens in Nevada. It is something that we have on as elected officials, certainly, and Mr. Driscoll, you've experienced in a unique way, and Mr. Brown, you've experienced in a unique way, that we do this the Nevada way. And sometimes that becomes very challenging. Oftentimes it can be frustrating for everybody involved. What I will say about this process is our great folks, Lori, who's here with us today, have really made it so that we could be successful as a board. And so I'm grateful for it. This will be the opportunity for us to have a discussion then about Dr. Kingsley's last year of work with us, the evaluation results. And so we'll open item 11 and welcome Ms. Griffey. And again, you have my great thanks for your work in this because it has been iterative. You've been very gracious and kind, especially as to me, who is an old dog, and you've had to teach some new tricks, and also Ms. Andriola, who has been really gracious to me in leaning in this process. So, Ms. Griffey, you have a presentation, I think, which is brief, but I also asked Dr. Kingsley if he would like to make a presentation. So I'll let you start out, and then we might go the other direction with him.
Sounds good.
Thank you so much.
Good afternoon. For the record, Lori Griffey, the HR rep for Northern Nevada Public Health. Dr. Kingsley's annual feedback survey process, questions, and list of participants were approved by the board at the March meeting. The survey was distributed to the list of 88 approved participants on March 27th. Email reminders were sent to encourage participation on both March 31st and April 2nd. The District Board of Health, or the District Health Officer's feedback survey results are in your packet. The 360 feedback survey process utilizes a weighted component format, and your packet includes 2 separate score ratings. The first score is compatible with the 2025 360 survey as it includes the same 3 groups of participants. The 2026 and 2025 comparable data can be found on page 6 of your packet. The second rating score includes the original 3 groups and a 4th group of participants, staff who supervise, that were added this year. We are providing the 2 separate ratings as the first score provides the board with comparable data to last year's survey, and the second score provides the additional input from staff who supervise. The results have been compiled and are in your board packet for your review. The second page of the packet has Dr. Kingsley's overall comparable rating for 2026. Further information Further into the packet, you will find the survey results, how each question was scored, and the overall rating. The scores were averaged by section and then multiplied by the weight of the category. The overall score was assigned based on a rubric 3-point scale. The 2026 comparable feedback results received a 2.08 overall rating. Based on a weighted average of all the components, this score does fall within the effective rating. The second feedback rating, which includes the new group, staff who supervise, received an overall rating of 2.07 based on the weighted average, and this rate also falls within the effective rating. There was good participation this year. We had 100% of the board members who participated, 100% of the internal leadership and direct reports. We had 66.67% of the stakeholders who participated, and 70.27% of the new group staff who supervised participated, with an overall participation rate of 84.24%. This participation rate is the highest we've had in many years. If Dr. Kingsley receives a satisfactory evaluation from the board, his contract will automatically renew for another year, and he would be eligible for a 5% merit increase, which is standard for county employees. Staff recommends the board accept the 360 feedback survey results as presented, and if possible, approve Dr. Kingsley's merit increase for this year. Before we turn this item over to Chair Reese, so the board can conduct Dr. Kingsley's evaluation, set goals, objectives, and expectations for the coming year, I do believe Dr. Kingsley has some information he would like to share. And we also have Patricia Hurley, Chief Human Resource Officer, and Dave Solero, Assistant County Manager, here to help answer questions.
Thank you so much, Ms. Griffey. As I said, it's been a pleasure working with you. Each of us work with different HR components in the various boards that we sit on. and you are one of the finest. So congratulations to you for your hard work. Patricia also very gracious, and Dave Solero for their help in this process, because it does take a lot of folks to do the HR work that you do, but thank you for that. I'm going to turn now, and you said that we said it, scheduled it as having Dr. Kingsley go first?
Yes.
Yeah, perfect. Thank you so much. Dr. Kingsley, welcome.
Thank you. Welcome. Dr. Kingsley for the record, District Health Officer, and I'd like to mirror those comments. Lori, thank you so much for your time and participation and patience throughout this process. So, just wanted to review over my last year on some of the points and successes of my second year. So, points to point out: strategic leadership and governance. We advanced the REMSA franchise revision for EMS accountability and adaptability. We've had during my 2 years here, we've had 3 third-party reviews, both in CCHS, AQM, and EHS. CCHS and Population Health had a realignment and support based on the first third-party review. And then during this year, the EHS announced visits pilot is continuing forward, and we are working towards performance metrics and workplace culture as identified within that party review. But those have been very valuable to us to be able to enact change and transformation and help guide us on those points. And so, as always, change is always slow, but we have seen progress among our staff, and as well as points to being able to address for our community and the services that we provide. We've had successful interventions in tuberculosis, measles, and pertussis. Very unique case in tuberculosis. The first time ever in our history we were able to actually use our authority to ensure that an individual was not contagious to our community and received the correct care within a hospital, both legally and correctly. And staff went above and beyond and what that individual experienced and what we were able to coordinate with that individual with another state. We did have our first measles case. And again, staff and their time and that was put into that and the care and the focus on that. And then as over the last 4 months, our pertussis ongoing outbreak that we've been doing and responding and working with our community, very much making sure that staff feels supported, enabled, and being able to respond to that successfully. We had the completion of our District Board of Health strategic plan with transition to the next 3-year plan. So when I began, we were midpoint in the previous strategic plan. And as direction from the board was to continue forward with that plan with no changes. And so we have begun that next process of our next 3-year plan and beginning our workshops with our staff to be able to identify from the direction that the board has provided for a strategic plan so that I can help enable and direct with the board's directive on that for strategy. We had a realignment over the last year of leadership meetings to focus on increased transparency and shared governance, focused on informational versus transformational. Now we have a monthly series of agendized points of meeting both with directors as well as ODHO and AHS staff, then core leadership. And recently started in January, all staff that supervise, we have a monthly meeting with them and that at the end of the month. That in transformational there is beginning to do case studies as well as trainings for them so they can feel enabled and strengthened. 3 months into that and very productive and positive, and also including all those that supervise in those meetings. We also had 2 surveys during this last year to help identify where we can improve our workplace performance and our culture, both a PH Wins survey and Washoe County HR surveys, and a WCA survey that also came out post these ones. From that, I began an all-staff one-on-one for both for transparency and shared governance, about 3 months of that. So based on their birthday months, a meeting with each staff members to get feedback from them and their input. This have been wonderful meetings and wonderful points that staff has brought forward, focusing on what is transparent communication, as well as what do they need to feel supported and valued in their position, and any one point they can see to help improve. And so I've received valuable feedback on that and been very positive meeting with the staff, and so that will occur during the rest of this year. And then increased operational communication, the whys. We are focusing to help provide our staff with the whys of decisions, as well as incorporating to them What I'll say from the one-on-one staff meetings I've had with them and staff is transparency, but also boots on the ground. Similarly, what we just spoke about with fire agencies is that those staff that are boots on the ground, that shared governance, what inputs are they providing, and they want their input and as well as valued. So it's been some key points that they've brought forward and some great ideas that we'll be moving forward with that and being able to ensure that their voices are heard as well as and part of that shared governance. And they understand very much that shared governance is not shared decision making, but having their voices there and heard and representative is important. Performance metrics, just overall, but with our partners, increased biannual communications accountability with our interlocal agreement partner boards, providing those biannual updates to the boards and accountability for those questions. Started that during this last year and have enjoyed going to each of your boards to be able to be there, be accountable to you, but as well as provide the information of the health district. We've increased availability and accessibility to community partners. In the UNR School of Public Health, we've had amazing programs. We began shadowing programs for their students, as well as a community advisory board and participating with them, as well as upcoming, as part of the process too, being involved into it over the next year. The Nevada State Public Health Laboratory will be moving from the School of Medicine to the School of Public Health, and so we're looking to improve processes there on both early detection as well as testing. It's a project they're working with Dean Muge and have been wonderful partners there with us. Numerous community associations on meeting with them in their public where they are at, Chamber of Commerce and presenting there and being a participant of that, neighborhood advisory boards, making myself available and accessible to any of those community members out there. And it's been wonderful to be out there and communicate and be part of those processes. We have seen a decrease in environmental health services related complaints from stakeholders and community, while an increase in EHS deliverables. This is really a point during my first year, but that has continued forward. And so it's been good to hear that those complaints, now there's always various ones that come in, but the larger complaints that we saw so many years ago, the community, we felt that we have worked with them and been able to address and meet those needs, which they expressed to myself as well as my staff. And meeting with you and asking, has those numbers gone down? I've confirmation on those points, any large of what previously we saw. And I continue to provide a prompt response and partner to community, to our partners, both the county, any county, Sparks, and Reno, to be able to provide and those community inquiries that come in and to be sure they get a prompt and prior response. If not noted, so previously there is a scorecard that is for public records request as well. And we did very, very well in that. And so we were happy to see that both staff, that it is important for us to be interactive with our community. Budgetary achievements, we know that we are in difficult times across the board, both state and federal. During my first year, we put the goal of a 10% reduction, as well as using that through our vacancies. In our fiscal year 25, our salary savings, we were able to save $1.5 million. We are in the same projected increase for our fiscal year 26. We'll have those numbers to you following the close of the budget. Increased efficiency through modernization. So it was, though a challenge, we had been previously above the base for an informatics bringing, and it was a challenge, do we bring this person on during this time? But bringing that informatics component on has saved us the equivalent of 3 FTEs. And so it's been a wonderful point that we've, that enabled that, yes, direction-wise, please hire this individual, and been able to follow forward on that. And it has brought that doing more with less. And it's been a wonderful process, and what has brought in many of our dashboards because of that informatics specialist that was brought in and hired. Continued representation to secure $2 million from the state. So we were put into the governor's budget. We have reported, and we were spending every dime and ensuring that we're spending every dime penny of that to the state, and have been reporting to that. But we're receiving that, so $1 million a year. So fiscal year 27-28, we do receive $1 million from the state now in uncategorical funds, and that has been beneficial, essential for us, especially in our epidemiological services, due to the loss of federal grants. Establishment and ongoing partnership with the county. So during my first year, we met various times, but I saw the importance that this year moving forward, we needed further alignment. And so we met monthly starting last September, sometimes more than monthly, but meeting with them on a monthly basis to ensure that our the processing and preparation of our budget was in line with those budgeting principles, as well as receiving direction from them on the management of it. In April 2026, seeing that where we are currently at in our budget process, I initiated a budget congress that has begun. We are exploring a priority and performance-based budget and doing that with staff, as well as analyzing each one of our programs. Thankfully, Mr. Centeno, the director of AHS, had worked previously at the state and managed with those budgets. So he's been a value process in that. So with our core leadership, we are going through that. I think the biggest thing from that, what I've seen over the last year, is how we tell you the story of that and how do we prioritize and how do we, with our performance. And so where we are already set up many ways in that with our objectives that we set up, it's been a priority. So I started the Budget Congress, and we'll be getting debriefs as throughout this Congress with you to make sure that we are correctly aligned on that. But we hope to have that budget and result of the Budget Congress beginning in September 2026. And then our state and federal partnerships for advocacy and representation, just want to say how important these have been, both in our state and representing and getting the uncategorical funding, but also at the federal level has been many challenges through this year. And both were grants that we have lost and some that we have almost lost and got back. On one in particular, it started at 8 o'clock in the morning on a Saturday, and that was for our public health infrastructure grant. And I was one of the 5 states that responded and worked with our federal partners through that. And we got up to about 15 other states that we were like, hey, I need this information. How much do you spend? We have to be able to go speak with our representatives. And I provided Nevada's information on that, and within 4 hours, they were able to turn around FIG. Similar to the SAMHSA grant that was reversed. It took about 2 to 3 days. This one, thankfully, only took us 1 day. So it was great to be able to have those partnerships at our federal level to be able to respond and advocate for public health. Communications, expanded visibility. We are prompt, informative, and press releases. We are bilingual accessible. I've done numerous interviews on that when bilingual staff is not accessible, and making sure that equitable information is provided, and happy to do that. Transparent, accessible media with staff matter experts. And I say that I always try to put them forward first. They're the matter experts. And when they're unable to, I fill in. But they are doing wonderful jobs and making sure us seen and telling our story on the community. And we have a strong social media presence, and just the wonderful points that is our very active in social media presence, and continuing to help to enable them and make sure that they have the resources that they need. I like also report that working with Mr. Oxerod and digital accessibilities, that we do meet the qualifications that put forward for our government. We are in compliance as of this month for our PDS being optimized, and so we're compliant beginning forward this 2026, and so happy to say that we are. And looking out there in many other communities who are not ready, the efforts that were put into that, I'm glad we were able to focus on that over especially these last 2 years. Accreditation and quality improvement. So we did go through a reaccreditation. I was part of that site process, as well as ensuring that reaccreditation we did achieve and met those standards, enabling staff to be able to move the needle where needed to, that they had the resources and support they needed to achieve that. Our 2027-2029 community health assessment currently continues in progress, but that was, again, ensuring that continued forward. And then we are wrapping up our 2024-2026 Community Health Improvement Plan highlights, but wonderful interventions that the board has made in these economic investments and up to within our community, where we're impacting systems, necessarily where we can't be, but impacting those systems. And we hope to continue with that moving forward. Quality initiatives, we did over the last 2 years begin a QI team and process. It does need some more improvement, but we're continuing forward that with our team, our internal team that is working towards QI. It has been formed, but it definitely is always a process to improve, as well as address those items that brought forward to them. Integration of staff performance metrics to add performance measures to strategic plan. That's something that I've focused on a lot over the last year, to be able to provide you with the correct information on our performance, as well as where we are with our staff. And this is integrated a lot into our budget. We began our internal workshops for not only for this year's strategic plan, but also moved towards and directed to have staff also include a workplace cultural strategic plan. So we should be delivering to that of you as well. I believe that is important and seeing that across the thing, and not only with the interactions had with staff, that we are setting the correct culture and meeting that. And that also helps us to be able to set that standard for our staff to be able to say, hey, we are not meeting our cultural plan, and be able to better be incorporated into that. Overall, as indicated, I increased employee value and recognition. That was a point for me, that they felt value and recognized that they can be supported, and gone out of my way for that, to be able to make sure through their engagement and support of that, they feel that they have a pathway to myself, as well as to their directors, as well as to their supervisors. So identify information transformation, and looking over my surveys, so where I can lean into this year, and I feel it's important, is clear direction on strategic initiatives. I believe not only from you as participation to me, how do I take your strategic initiatives and make sure that they are enabled within the organization and operationally. So that's my number one, that I am prioritizing on that there's clear strategic initiatives and that we are meeting those. We have a lot of great infrastructure there, but something that perhaps is missed over the last year, but how do we integrate that? My second is managing organizational change. Change is difficult. We do have some change and continued change, both with our budget, but a clear, defined process for that to be found out. And then third, trust and collaboration and communication clarity. These are the three priorities that I'm setting for myself for this next year, but happy to hear from the board on other priorities on that. It's basically the what to the how. And so working with my directors already began to address of, in the next 90 days, what would you like to see me accomplish and how, as well as during the next year. What I found challenging from the last year was that I set my SMART goals and set my goals, the what to how, based on the comments as well as direction from last year. But it's not as transparent and easy during that evaluation process because of the anonymity of it to be able to do it. So sometimes I want a better process to say, okay, this was expressed in here. I see these points. How do what do I need to stop doing, and what do I need to start to do? But also, where is the leadership change through that? And so I need to provide that clear direction through that, but also have their input that has clear objectives and purposes as any of our staff that has a transparent process to their evaluation. But overall, that's my what is to convert evaluation feedback into concrete leadership practices to improve clarity, change, execution, and trust. Immediate changes, thank you for meeting with me. What I inherited 2 years ago, and both in communication, is sometimes from a fair weather board or points, but there was improvement. Member Anderson provided wonderful feedback on a 2x2 process they do in Sparks, and I met with manager Dion, and to be able to discuss how that occurs. And so expect invites, annual invites from Jackie setting up those processes. So we'll begin 2x2 processes the week before our board meeting, where you will have the agenda and provide that. And I will be as flexible as I can, both phone calls, in person, or Teams, whatever works for you, but providing those 2x2 meetings from that wonderful example and moving forward. And also seeing if that's sufficient for once a month or twice a month in where we're at, or perhaps second portion of the month is something just an electronic update of currently what's going on. But it has been subjective, and I wanted more of a process portion of it to be able to provide the information interaction with you. A second, too, is moving to have a district board health agenda item for district board health updates and information, just what I am working on and feel informed, and what I can be bringing to you to the next month, so you feel informed or be able to provide any interaction on those points. I feel those were two important immediate district board health changes for our communication. And then overall, today, too, I would like to request an evaluation process request that within the next 90 days, I'm requesting that staff bring back for board consideration an updated evaluation process that is more transparent, inclusive, directive, and transformative, while remaining compliant with open meeting law, performing qualitative and qualitative data analysis, and ensuring the organization has the right readiness and support structures. Part of that would be not only my staff, but it would be also the county interacting with county HR and the processes. I believe that even the county manager and other processes are exploring the next iteration of these annual processes. And so I would like to, sooner than later, so I have the whole year for the evaluation to bring back, and that it's in alignment with you and your directives for the next year. So that was one of my requests ultimately from it. So thank you. That was a little bit longer, but I just wanted to be able to, it's a lot to summarize up into 1 year into that process, but thank you very much.
Dr. Kingsley, thank you so much for the presentation. I'll maybe start us off in part because I have to spend the most time with you, I think. And so I've had a unique perspective the last 2 years to be able to work with you. And so please take my comments both in the spirit of grace and also in the spirit of helping us to situate ourselves for our conversation today, because I think there are some real strengths to highlight, and there are some areas for continued growth, which we all have. And I think human nature suggests that every time we hear a negative, we think that that's like an attack on our personhood or anything like that. And I don't believe that. I think that I'll have some positive things to say, and I want some positive understanding of where we're headed. The first thing I want to say is really a comment for my colleagues, because as I reviewed this packet, it's very comprehensive. There's a lot going on there, and the charts and the numbers that starts to boggle the mind. But I wanted to think about it in this perspective. The 2025 scores were really first-year results, which are often buoyed by, I think, goodwill and a fresh start, right? But for me, what I took away from it at a high level was sustaining an effective rating through a more scrutinized second year with a different and expanded evaluation process and a more complex organizational environment is a meaningful result in and of itself. So kudos to you, Dr. Kingsley. The honeymoon period, you kind of get through that, and there's some things that happen in that are helpful, but maybe are not indicative of the long-term growth model that is presented. I was looking at the year-over-year context, and I note and will highlight that you've improved in your internal leadership, a section which most directly reflects the relationship with your own team. And for me, that was very meaningful. The community stakeholder engagement is also the highest scoring section at 2.24, with stakeholders consistently describing you as accessible, their word, diplomatic, and collaborative across the region and state. That was very important to me. Direct reports also gave you your highest single score, so 2.44 for evaluating and recognizing staff contributions. I think that is also a leadership quality worth noting. You delivered results on the strategic plan, which you highlighted here and was valued at 2.5, health equity integration at 2.5, emergency preparedness at 2.40, and the fiscal year 2027 budget approval 2.43, all very high scores. Multiple community partners specifically praise your handling of real public health events this year, including the measles case, which you highlighted, a mass casualty event, which was very challenging. And for me, that shows executive leadership under pressure. And so I'm grateful for those things. Areas where I wanted to see and think about growth, and then we're going to have some conversation here at the dais because I have some questions for my colleagues that may help us move this forward too, is about strategic direct communication with your team. I think this is an area where you've acknowledged and have been actively working on strengthening. The clear board guidance going forward into year 3, I think could support that progress. And you've noted it, interestingly enough, as one of the things that you're looking for. It was also something that I think is important. I might not have heard it, but I know that you have gone through this with Margaret Crowley. You've been doing some different kinds of training, but I didn't see how that was highlighted in the report. So is that a different process than what you were highlighting in the report? Because that's really about like mediation and mediating conflict. But I would have thought that that would have been included in the report because I thought it was an excellent part of your year. Was that in the report and I missed it?
It was not. It was
Okay.
a lot to try to summarize.
No, I understand.
But yes, wonderful process, both in communication with Margaret, with my team, as well as recent training we did towards mediation for our organization. Yes.
Well, and for the benefit of the body who might not know that the teams have gone through that, I think it is a very important part of advanced leadership because it's a skill that comes later, I think, in life. And Margaret Crowley is a local mediator who takes organizations through different programming. I actually would have liked to have participated to some extent, and maybe I'll have a chance another time. I want to finish with the continued growth things to make sure that I've made the points that I want to make, and then I'll turn it over to my colleagues. One is that employee satisfaction and workforce development are long cycle challenges that reflect organization-wide dynamics. I think this warrants continued focus for you in year 3 and also board support, but it's not for me immediately alarming. Board relations scores also reflect an effective working relationship, which means you've got a little disconnect between those two things. So the board will support, I think, by continuing to engage directly with you, and your communication path board says that that's what you do. So for my part, I ultimately concluded, and I know you can't see how each one of us maybe rated you, but I rated you as an effective district health officer, completing your second year, leading a large and complex public health organization, which would be reflected in my comments. Your stakeholder relationships are a genuine organizational asset, and your direct reports recognize your investment in them. You have delivered on accreditation, budget, community health assessment, regional partnerships, the rent and franchise, and the measles and TB related issues. Executive performance in a complex public agency develops over multiple years, and so I'm grateful for the opportunity to work with you the last 2 years, and I think that we're primed and well poised with your acknowledgments of some of these growth areas to continue that into the future. So those will be my comments for this time. I do have some questions that I have for the board, but I will leave those till after the comments, and then I have some concluding thoughts. So I'm going to start with my right on this end, and Dr. Duarte, that means I'm coming to you first if you have no questions at this time or comments.
I just commend Dr. Kingsley. I mean, running a large, complex organization and doing all the things he's done is very tasking and very challenging, and I appreciate his expertise and his leadership. So that's it.
Well, I'm very grateful for your insight because I do value the work that you're doing is of a similar nature, I think, and so it has some very similar overlap. So I'm grateful for your acknowledgement of that. I also heard a statistic, and maybe you can confirm this for me. I don't know if this is true, but the average shelf life of a person at this level, which would include your level, is about 18 months right now. It's a very challenging time to be in public health. So your kind words were very gracious. Thank you for that. Okay, Mr. Driscoll, did you have any comments?
Yes, please. Thank you very much. Looking at the numbers, as you know, that I'm kind of a numbers guy, and something that kind of popped out to me that I thought would be curious, and I don't know how we would determine this, but in the evaluation from the staff who supervise, there were quite a few lower numbers in those levels.
Yes.
And in looking at the questions and the ratings, the first thing that popped to me was not that you weren't doing a good job and that you weren't coordinating with them, but the people that were being affected by change were not happy about the change. And in my mind, we're taking it out on the ratings. That's just personal feeling and personal observation. Because I believe that there were other scores that were scored much higher that are directly related. So you had opposing views on what is theoretically the same discussion. So large organizations that have a lot of expertise differences between them, change can be very detrimental to that. And if we're used to being in kind of control and now someone's asking us to do something different, it goes from there. And so I believe with the conversations that you and I have had on some one-on-ones and broaching a few of those topics, that staying the course of where you are, pushing for the success of the organization and letting the little bumps kind of work themselves through, I think is a prudent way to do it. And I compliment you for your strength. Thank you, Mr. Chair.
That was a very interesting perspective. I wonder, Ms. Griffey, if you might come back up for a moment and just answer that question, in part because I don't think it's necessarily a question that Dr. Kingsley maybe could answer, but I think Member Driscoll is making a very good point. There seem to be, and I agree with the point being made, there seem to be two questions in the same sections that pitted themselves against each other. And again, I don't know much about this last part that Dr. Kingsley put at the end of the presentation about changing the way that we do evaluations. It's just something I'm not as familiar with. But Mr. Driscoll, I remember Driscoll is making a point. Is there anything there?
The questions for the new group were the exact same questions that were asked of our internal leadership and direct reports.
I don't think that was
questions that came over from 2025.
No, I don't think that was Mr. Driscoll's question, though. It seemed that there was like this an opposite thing where one was about what maybe you can explain it. One was about what Dr. Kingsley does and pushing out, and one was about what people do having reaction coming up.
Thank you, Mr. Chair. And I think it's not the questions themselves. it's understanding the personality and culture of the organization and knowing that there's stress there because of change. And so looking at questions that in theory, in my mind, and I could be way out in left field, in my mind, they were somewhat related. Yet we had ratings that were opposed. And to me, that just, my evaluation of the numbers, not scientific, and I don't have any detail any more than anybody else does, but just my casual observation said, this is a result of change. And my perception of people through a survey that they know is anonymous, kind of poking a little, hoping that maybe the change will back off. Yet you'll have another question that's, for all intents and purposes, the same thing, and everybody's happy about it, which means maybe the communication related to that was better received. And so again, I don't think it's an HR issue that can be solved. I think it's my perception, having played this game for a long time. Thank you, Mr. Chair.
The only recommendation I got is that maybe next time we can reword the questions to where maybe when they looked at them, they read them different than what we intended them to be. So that maybe next time we can just adjust the wording to where the questions aren't quite so related to each other.
Thank you so much, Ms. I'm going to turn now to my colleagues on the left. Ms. Andriola, you're up.
Thanks. So I think we could all probably have a workshop about how to make the best performance evaluation instrument. I don't know. I certainly have. I think that there is need, and I just won't keep on going on that, but I do think that there is need to look at the performance questions because I think one of the things that was missing, and I think, Dr. Kinsley, thank you for pointing out Washoe County's leadership in looking at having the Budget Congress and you adopting that. And thank you for looking at priorities-based budgeting, which is an initiative I've been trying to champion for several years. So not mentioning Washoe was a little surprising. And I think one of the great things about the relationship is the resources that come to an organization like Northern Nevada Public Health are the best of the best, truly the best of the best. Lacking that was a bit of surprise. I'll now go to, actually, the point of those questions were surprising because a lot of it wasn't necessarily, that's why I do agree there's room for improvement. The county, just for everybody's information, is looking at the county manager and a revamp of performance. And I think you were referring to that leadership that Washoe County has and the expertise that they're looking at and adopting that without a huge cost to Northern Nevada Public Health was missing. So I'm going to take the time to thank Washoe County for helping Northern Nevada Public Health, which you do pay for shared services. So I'm not suggesting it wasn't free, but what you get for that really couldn't be paid for if you were an independent organization. Having said that, there's always flaws in every performance evaluation. You could spend you probably get a PhD in evaluating performance evaluation. But just in looking at the comparisons, the fact that in 2025 was a 2.40 and you had a 13.33 degree decrease from comparing 2.40 to 2.08 out of the 5 categories, which were the exact same categories of 2025, were the exact same because the chair wanted to make sure those comparisons were exact. So thank you for that. But out of those 5 categories, 4 went down. And what was significant, even in adding the 4th group, the Northern Nevada public staff who supervised was your lowest score. So to Mr. Driscoll's point, we can only speculate. We can't define without digging deeper, but we can only speculate. And if people are using this instrument as an instrument to not share their true feelings, feelings are real. Perception is reality. And the reality is that it's lower. the fact that Washoe County, not City of Sparks, not the City of Reno, invested in leadership training to the tune of $13,250 certainly was a wonderful opportunity to be gifted out of Washoe County's budget to see that improvement, and we didn't see it. And that's just my interpretation, and I'm just one person. And so I think that there's a lot of room for improvement. I think that the fact that the WCEA had also put out their information from December of 2025, which was surprising. I don't know why they did that, but they did. And there was a commonality between 2025 and in that picture to what the results are of 2026, at least what we're seeing in those. And so if it was just an anomaly, to Mr. Driscoll's point, of just an opportunity of using an instrument to maybe not accept some change and not being acceptable in that direction, they had a whole year. So evidently that direction wasn't calibrated. And so from my perspective, I've not seen any improvement in terms of anything of any meaningful way from a leadership standpoint. And I think that the struggle of some of the things and navigating some of the things fall directly on leading an organization. The board sets policy. The board does not run the organization. We're real clear on our role. And I do think our role can only be gathering the information that was provided, but then looking at your position as a position to actually help us help you navigate that. And it seems that there's been nothing but struggle. And I also, just in looking at some of the comments about not necessarily using some of the expertise that you have the ability within your own organization, seems to be something that's highlighted both in the WCEA and also in the results of this, and just some of the comments. And it's not all the comments, so I don't know. You know, you can't, it's not like we're going around asking every single person. But I do see some comparisons that really, I don't have the confidence, to be blunt, and being very respectful. And this is a hard thing. It's a hard thing to be in public. The chair said that. It's a hard thing, but I can only share what I am going to be respectfully sharing. And that's that I believe that in working with many other organizations who are both larger and smaller than Northern Nevada Public Health, and spending years in executive leadership as well, and recognizing that there hasn't been an improvement really, again, gives me pause and actually has a very minimal lack of confidence. I just have a huge lack of confidence of change, given the ability for the investment, given the ability that you had the feedback, essentially, I don't want to say it's exactly a year ago, but you had feedback, and that it still seems to be, you know, carrying forward. And so from my perspective, I believe that you have tried your best, but that the position you're in requires the leadership that is expected, not the leadership that we hope. And so from that perspective, it's been a big struggle, I'm sure for you too, to be honest with you, in navigating, recognizing that there are challenges, but those same challenges also are in the same others, whether it's budget and some of the other navigating challenges. Every organization has challenges. And I just think that given the fact that Washoe County has invested in trying to help through that, and I know that there's probably even board members who have helped as well, I just haven't seen the executive leadership needed to actually run this organization that has really huge consequences, in some cases, life and death. And so I hope that you understand I say this with real respect, and it's not something easy to do in public, but I feel that not, as an example, listening to some things with those experts, whether it be legal or whether it be your staff, and you are ultimately the person that makes the decision. So I'm not suggesting every time somebody says something, you have to actually go in that direction. But some of it has been very clear, and it seems to not necessarily be a trust but verify. It's a kind of your way or the highway kind of interpretation, just an observation. And so I think there's, I'll end it by just saying, I do appreciate your understanding how difficult it is for me to say all of this, as I empathize on how difficult it must be for you to hear. And I really appreciate you giving me at least that consideration that I'm not saying this lightly. But I am saying it with not just emotion, but with actual quantitative data and plenty of time to see some improvement. So with that, Mr. Chair, I appreciate you giving me that opportunity.
Oh,
Thank
yeah.
you.
Thank you, Ms. Andrioli. I appreciate that. Mr. Anderson, you're next up.
Thank you. I want to say that I appreciate the work that you're doing. As a couple of my members up here have mentioned, that you're running a very complex organization, a lot of moving parts, a lot of individuals working on complex issues. You've also experienced an unusually difficult year as far as your funding and trying to figure out whether it's federal, state, or local, how you're going to keep that organization solvent financially. So you've been tasked with some really difficult issues. Not to mention, as we talked about, the REMSA, agreement, and that franchise agreement was very complex as well, very time consuming. And I thank you for the work that's being done on the strategic planning. I think in the past, historically, a lot of organizations have kind of let that slip by the wayside, focusing just on the fires, whether it's financial or whatever, and not looking at that long-range plan of how we're going to get to a better place. So I appreciate that. As well as, like you mentioned, the discussion that we had and you were able to have with Dion, kind of talking through, and I'm never expect that you're going to do exactly like what we do in Sparks, but it's something that works for us on the communication side with the staff leadership and us at the council member level. Likewise, I thought maybe it could be something you'd look at. And I appreciate you discussing it with Dion and kind of understanding how it works, because it really does improve that communication side. For me, personally, that was actually one of my biggest concerns over this last year was what I believed was poor communication between us. And I'm taking some of the blame myself on that, because I should have reached out to you more often to have discussions. But I really believe it's going to help us, and likewise your staff, internally, to be able to have a clear understanding of where things are, expectations, and giving us all an opportunity to ask those hard questions. The other thing that I would ask you to consider is, along those same lines, we in Sparks have started doing something recently over the past few years of, in this case, it's the city manager with his leadership team getting together once a month and allowing them to have a discussion to where you may have folks from another portion of your organization that don't even realize this is a struggle. Or likewise, someone succeeding here and someone else may be able to utilize some of that information to succeed or have a greater success in theirs. So just in that side of it, because looking at this, that was one of my concerns, was the communication side, both internally and then likewise with us as board members. I am concerned about the scores because it was a marked drop from the 2.4 to a 2.08. And then especially even from the supervisory level, having, the 1.9, which is minimally effective. I'm concerned about that. It's not the trend that you or we want to see. The good news is that you're not at the top and there's only one way to go. So you definitely have room that you can see some improvements. On the communication side, I believe you're already starting to look into avenues to help you out with that. On the leadership side, that's also a concern of mine. To see some of the comments from some of the folks, and whether we look at the scores and say, well, maybe this is because of internal strife or whatever it is. In my opinion, does that really matter? I mean, will we ever know what those things are? All I can look at is the numbers. And, when you see numbers like a 1.79 from your supervisors, and then it just, you have some work to do. So with that being said, as far as the leadership side of it, I'd say there's a gap. And I really want to see improvement in that category, that clear, concise direction. Your team knows their expectations that you have of them, and how to move forward, as well as the leadership as a whole on the organization. And with that, like I said, the good news is you have room to grow. So thank you.
Mr. Anderson, thank you so much. Mr. Brown.
A lot's been said, and as our chairman said, I've sat in this hot seat before in public and watched these things take place, both fit myself and I sympathize, but I also think this is a great avenue to hear truly how people feel about you, how things are working and what's not working. And we've talked, for the last 2 years you've been here, and, we have our strengths, our weaknesses, and when we see these weaknesses, potentially, I don't view them as a weakness, but it's somewhere where we need to start improving. And this gives us a perfect avenue to start. You've been doing it. But again, after an example like this, I think it's something that we just need to continue with. As Mr. Anderson said, there's always room for improvement. I can remember my evals were 1 through 5. You're not going to get 5s because that's, there's always ways to make yourself better. And so with everything said, I think the point's been made across. I appreciate the conversations we've had, a lot of information on our last one-on-one, and I appreciate the, information you have coming from the employees, the same way. I think that's great. Communication on what's taking place in our community, very effective. I haven't seen that in, prior health officers and to the extent we're getting it from you. I think it's coming from you, but I also think it's your staff. You've got good people, and those people are doing exactly what they need to ensure the safety of this community through you. So appreciate all that, and we got a lot to do here and a lot to keep going on. So thank you.
Thank you, Mr. Brown. Any other questions or comments at this time? I'm going to come back to you now, Dr. Kingsley, because I want to make sure that you have the opportunity to say any words that you might like to say. Oh, Dr. Duarte, you were back in. Sorry, I didn't see that.
I don't know if it's appropriate. I was going to ask Dr. Kingsley if he would be, I'm going to set an invitation that if there are things that I can do that would be helpful, please let me know, because we also need to be part of helping him do his job effectively and better. And I want to be the first to extend that invitation.
Well, that was very gracious to you. I was going to pose some questions to the board, which naturally come from your inquiry, because as I saw it, there you have some good things and some things to work on, right? You have one colleague who really wants to see some serious and market improvement. I wanted to ask, and these were board questions really, and I had 3 of them after I thought about this for some time. And Dr. Duarte, I think it comes from sort of the same place you are. And the first is, what specific goals would this board like to set for Dr. Kingsley in year 3, and how would we measure progress together? And these are rhetorical questions, not necessarily I'm demanding your answer here on the spot. Second was, how can the board better support Dr. Kingsley's work on internal communication and strategic direction across the organization? which I think is what you're highlighting. And then the other thing is what resources or partnerships would help Northern Nevada Public Health address employee satisfaction and workforce development in the coming year. And that sort of, I think, is at a board level. And in that regard, Dr. Kingsley, I'm going to come back to you because we've all had the opportunity to say a few things and say to you what I have often told people who are in the position you're in, which is it's hard sometimes to hear, but it's also the opportunity for you to grow through it, right? We certainly grow where we are planted, as the saying goes, and there are high expectations for the job that you hold, in part because it is a life and death situation. And fortunately, I've been with you this year where we've had to deal with a couple of those things. A call on Christmas Eve about a person who's got an infectious disease and we're trying to go to court on them, right? I mean, these are things that are very serious. But for my part, it's sometimes people in leadership, they take the information, they process it in a way that turns out to be a bad thing for them. Other times they take it in a way that is a good thing for them. And my experience with you tells me that you'll be one of the latter and not the former, right? That you'll have the opportunity to take the information and react to it, not out of anger or malice or sadness or anger or frustration, but out of the nature of leadership, right? Because what we want is a health officer who will stay for 25 years, right? And so, and those are not always going to be easy years, and sometimes you have different things going on. So those are sort of my thoughts as we close this item out, and I didn't know if you wanted to be able to say anything in response to what you've heard. I do think there are opportunities, and there will be opportunities for me and our HR staff to really lean in and work with you in the coming year, and we'll sort of address some of these things.
Just want to say thank you for the input and for the time and opportunity and trust and those things that you're exhibiting. And very much so, yes, I appreciate very much the very first, what specific goals does the board want me to see and how do you want to see me achieve them, or what is achievement on that? And that direction alone, I would appreciate from the board for those direct things and what does achievement look like. And so very much so on that interaction with the board, and then in next few meetings or whatever, as we can specify those so I know what to achieve and how to achieve that through this year. I just want to say thank you. And exactly, it is. We all have opportunities to grow. We all have challenges, but we also have wonderful strengths on both sides. And I appreciate each one of your strengths, and they've been valuable as I've spoken with you, and the insights and the opportunities that you provide me, and I'm grateful for that. And for growth, I think growth is, if we're not growing, we're not doing something correct. So I look at that and I'm appreciative of that opportunity, and I'm appreciative working with my staff and the time I've put into them and the opportunity that they've given me. And the same thing, doing the same process with them. I went to them and I very much the same point. I'm not asking you to be nice. I'm asking you to be kind. And it's not about being nice. I need the feedback and I need the direct thing so I can take actionable items to make those changes. I just don't need information. I need transformation. And so I need those actionable things that can transform me. And so from this, I've got the information, but I need those transformational action items, both from the board and from my direct reports, on what is transformation and what is achievable, and setting those standards. Just from my staff that I advocate for them is, how do I make you successful? How do I set you up for success? I believe I'm also warranted that as well. And so that's why I'm also seeking that. What does success look like for you, and how's it completely defined? And I think that's important so I can achieve that. And so setting up, I think, is not only for my staff, but for myself as well as an organization. And that's a culture that we have to have, that we advocate and that we support and that we sustain, each of our members. And I strive that for my staff, that they have that excellence and they feel supported and they feel valued on those points. And so seeking the same opportunity for myself and those growth. And I appreciate that. And I appreciate the comments. And Commissioner Anderola, thank you so much for your honesty and that opportunity and what you've expressed. And if I have a goal, one goal is to prove you wrong and be able this next year to show you. So thank you very much. And same thing, Anderson, I highly appreciate that impact and looking for more of that interaction there and on those points, and happy to address that and to work with you through on those points. So thank you very much and for this opportunity. And thank you for this community too, because it's been wonderful to serve them, what they've done for my family and being here, and the support I received from so many others too as well. It's been wonderful. And this is an amazing community, and home does mean Nevada. And it's wonderful to see where our communities and what we've been provide. And for my staff, they have been wonderful staff. And it's been wonderful to get to know them and their lives and what the impact it has, meaning working here as well as in the community and the challenges that we face, but also to be able to go home and say, I made a difference in someone's life today. So very appreciative of that and this community and what it is and the cohesiveness and how we can improve it and that and what those decisions we make today and what it's going to look like in 20 years. So thank you very much.
Dr. Kingsley, thank you so much. I didn't know if you were raising. Oh, okay. Thank you so much. I'm going to, Dr. Duarte.
I just wanted to make a comment from something I learned in one of my classes, and that's an organizational structuring. And there's forming, storming, norming, and performing. That's right. And you've been through the honeymoon. We're in the storming. I'm hoping we get to the norming and the performing. So, and I think we need to give Dr. Kingsley an opportunity to show us. So,
Yeah, no, that's a great way to look at it. I think I said that it was the honeymoon period, and now you put a few more legs on the analogy, which I appreciate very much. Thank you so much for that.
Chair, I'd like to note for the record that Dr. Danko did leave at 3:00.
Yes, I saw that. I had the opportunity to speak with her briefly, and so I know her thoughts were positive, and so I'll just leave it at that. But I appreciate you recognizing that and for the record. Okay, I'm going to hazard a motion then at this time, and I'm going to move to accept the District Health Officer's Annual 360 Feedback Survey results, renew the District Health Officer contract for a period of 1 year, and approve a 5% annual merit increase. That would be my motion as in the staff report.
Second.
Okay, I have a motion and a second. Any discussion? Hearing none, I'll.
Mr. Chair.
Yes, please. Abby.
Just for a point of discussion on a couple of things that were just discussed. When it comes to the next step with this being approved, being goals and objectives, something that Dr. Kingsley asked for, Dr. Duarte was reinforcing, is I think if there's a goal, the goal has to include what does success look like to achieve that goal. And if we have a goal that doesn't have that, I personally would not accept it as something to hold the director accountable to if we can't share with him what it means to be successful. So thank you for the conversation.
Well, I think you've made a very good point. And what I guess I would say is we're going to get through the motion. And my comment would be that Ms. Griffey is here with us today. I think has heard a lot of the feedback. I think it will be incumbent upon maybe one or two of us, and it might be the two of you gentlemen, just because I can look at you and put you in the hot seat, who have got to come with us into that conversation, and you have some experience to lend to it. And so I'll invite you to that point in a different way, and Ms. Griffey will help us to get there with those kind of measurables and some of those kind of things. And I think we can do that in the coming weeks. Dr. Duarte? I think I want to make sure we've had a motion, which I've made. It's been seconded by Member Driscoll. Any additional questions or comments at this time? Hearing none, I'll call for the question. All those in favor, please signify by saying aye. Aye. Any opposed?
No.
Motion carries. Okay. Thank you so much. We'll close item 11 and move on now to some of our staff reports and program updates. And, you know, we haven't had these in a couple of meetings because we've run into staff or just timing issues. So I'm going to see what we have today. We'll start with item 12A. 12A is a report from Mr. Vega, air quality management side of the house. Hello.
Hello.
Good to see you. We don't always get here, so I'm happy to have you in front of us. I did read the report. Excellent and fantastic. Thank you so much for that. Anything you'd like to add?
Just a couple of things really quickly. I always like to highlight where we at with plan review, because I know it's been an important topic. So in March, we were at 90% of plan reviews completed in a timely manner. Again, I just want to commend the team in their efforts, because that does take time and it does take effort, and they've made it a priority and they are being successful. So again, want to recognize the team for that. Really quickly also, I didn't get to mention it last month, but this burn code season, we also had no red burn codes. So that continues that streak of positive wintertime air pollution. Also wanted to mention that we accomplished this burn coat season, and one of my challenges to the team was historically we'd done this with like overtime or comp time. And I challenged them to come up with a way to do it and accomplish it through either technology or other improvements on how we can accomplish that without the comp time and overtime. And we were successful. So again, I really want to recognize the team for taking on that challenge and then being successful, and then also having a very successful burn coat season from an air pollution perspective. So again, a lot of kudos to my team. With that, I'd be happy to answer any questions.
Mr. Vega, and I'll just ask, what do you mean by no burn code happenings? There were no issued warnings?
Nope. So all of our, so from November through February is what we call our burn coat season. And so every day we put out a, red, yellow, or green burn coat. Every single day was green, which meant we had like perfect air quality.
Okay, perfect. Because I thought, I was just making sure it wasn't related to the air quality, because there was one day, maybe a month ago, where I was, my eyes were burdened because we had some controlled burns going on near us in Dog Valley. So now I understand what you're talking about, and so thank you for that.
Yeah, of course.
Any questions for Mr. Vega? Okay, thank you so much.
Thank you.
Item 12B is our Community Clinical Health Services, Christina Shepard.
Good afternoon, members of the board. Christina Shepard, Division Director for Community and Clinical Health Services. I just have a couple of brief updates. I didn't get a chance last month to celebrate World TB Day. And so since we did cut the ribbon on our new TB clinic, I just wanted to really commend that team for all of their work. These team members support the clients that are being treated for active TB through 9 to 12 months of treatment. They help them maintain complex medication regimens, manage their co-occurring health issues, and oftentimes navigate challenges such as unstable housing or food insecurity. So their commitment, patience, and compassion really enables the clients to successfully complete treatment, move toward better health, and protect our community from further spread of TB. So didn't get to say it last month, so I wanted to make sure I shouted out that team this month. Our family, just one thing from our report, our family planning sexual health program, we are navigating a shortage of the primary medication that's used to treat syphilis. So right now we are in a medication conservation plan where we're reserving our doses for pregnant people, since that is the only treatment for them, and any patient that has a contraindication to the alternative treatment, which is doxycycline. But on a positive note, our clinic staff has successfully initiated a client on injectable PrEP for HIV prevention, overcoming the very lengthy and complex approval process. So I want to congratulate them on that, because that was a huge accomplishment for the clinic. So happy to take any questions.
Ms. Shepard, let me start with the TB portion of the world, because we were across the street, and I want to just say thank you to all those involved in the ribbon cutting today. And I got the opportunity to tour the facility. So that clinic in that building is under your division. I apologize. I would have liked to have recognized you over there. I saw you. We talked. I got to wave, but I would be remiss not to say thank you for that. Is your office over there, or are you still here in the mothership, or where?
I wish I was over there.
It is a beautiful building.
Yeah, it is a beautiful building, and so
I just didn't know. I
Yeah.
mean, it was a beautiful building. It's a very light-filled place. But thank you for that update. I appreciate it. So
Furniture is moving now, I think.
she's ready. She's in. No, I definitely don't have that power or authority. But thank you. Any questions for Ms. Shepard? Okay, thank you so much. Item 12B is closed, and 12C next will be Mr. Fida, Welcome Environmental Health Services.
Good afternoon, Board. Robert Fida for the record, Environmental Health Services Director. So I wanted to highlight some of the continued good work that we keep doing. One of our staff members, they've started hosting a Spanish version of the AMC program, and that was actually done at the end of March. It was well attended and a lot of good engagement. This is to help some of our folks with maybe not English as a second language, provide them the opportunity for education and for better knowledge base when kind of assessing food risk. I know it is a challenge for our folks and for those folks to get that intervention sometimes in the field, so it helps that they have some dedicated resources. Our team is also in the process of doing lots of improvements. Our food plan review team is working with City of Reno business license team to kind of work out, I guess, an amendment process and make some changes in our internal processes to kind of help streamline some things. So they're looking at that. And our mobile team is also working on, they finalized a new Acela record to help streamline some of that application process. And this is kind of in preparation for some other steps. We have another project that's in the development phase. It's an app for food trucks. So we're hoping that with this record creation, we can kind of start moving on that. And then another thing of interest potentially is that our staff also did some follow-up with a food establishment. There was a report of 8 ill employees with similar symptoms. So our staff went out, collected samples. We're still awaiting results on those. And then pool season is upon us. Our permitted facilities team, they actually opened up their online booking site. That's in full swing now. So that provides the opportunity for those folks who want to open their pool. They go online, schedule it, and online management of their appointments and whatnot. This is the second year we're rolling it out. We've had success last year with this program, so we're hoping that we'll see similar results. And then the other thing is our Safe Drinking Water program is doing essentially their auditing for 2025. Any missing samples are now being essentially tracked down, is the best way of putting it. Some of them may be with labs still pending. Others maybe weren't received. So our staff is working to make sure that the 2025 water quality data is accurate and that any violations that are incurred are appropriate. So they're in the middle of that process. That's probably expected to be completed soon. And that's pretty much what I had to highlight. I am open to any questions if you have any.
Mr. Fida, remind the board how many pool inspections will have to be done between now and I think Memorial Day was kind of the marker that I always thought about.
I was going to say, normally we open the window a little earlier, so we try to get April. There is Memorial Day seems to be the very popular date, and there are, I think, about 600 pools that would want to be opened around that date. So we try to, I guess, put it as a steady trickle instead of a deluge. We've had issues in the past where people wanted to open and we didn't have the capability to serve them on Memorial Day weekend. So we've kind of invented this system to help kind of space out and have people plan appropriately. So, and this gives them the opportunity to book, be prepared. It even gives them reminder emails and all that stuff. So it's a fairly, I think, a great system that's in place now. So.
No, it sounds great. May the 4th be with all of you in that endeavor. Any questions for Mr. Fida? Mr. Fida, thank you so much. We'll close item 12C and move to item 12D, Population Health with Dr. Dow.
Good afternoon, Mr. Chairman, members of the board. This is Nancy Dow, Division Director over Population Health. You'll have my report. I have nothing to change or add, but I do want to give a little bit of an update on our disease front. You heard a presentation from our EPI team in the last board meeting on the increase in pertussis, and this continues as we reach 25 total cases now and 3 school-wide notifications so far in 2026. So the increase is still happening. We're at over 80% of 2025 totals as we reach just a third of this year. So our EPI team is continuously to work closely with our school district, which is mostly school-age children that is affected, and our partners for infection control and prevention. Also, quick updates on our respiratory diseases front. We're now into late respiratory season. This season, we did experience the highest peak in influenza-like illness we have ever seen compared to the past 5 years in late December, which coincided with huge peaks in flu hospitalization, emergency department, and urgent care visits during that time. Washoe County's influenza-like illness activities have gone below our regional baseline by the end of February and has remained low currently, which is good news. And we did start to see flu B instead of flu A only since February, but that has not induced a second peak in the season. Our RSV peak this season came on late as well, usually increasing around December and peak around early January, but this season we didn't see RSV peak until late February. Our cases have started decreasing in the month of March and currently is also remaining low, and our outbreak numbers have also gone down in the month of March and also so far in the month of April. Since July 2025, we parsed out in the Population Health Division the Statistics and Informatics program. While we only had one staff brought in and has a working supervisory role for that staff, to support our needs informatics per request, I would like to give an update on what we have produced in the past 10 months so far. Outside of our statisticians' regular numerous data extractions, data management, and support to programs that remain in place, the program has published, in collaboration with various programs in the Population Health Division, 3 external dashboards for regular data and information dissemination, 4 internal dashboards for work performance assessments, internal data tracking for our volume-based disease programs in epidemiology and sexual health. There has also been various data extraction pipelines set up now to run in a completely automated daily schedule for data population. All these are not only saving hours in our staff's time, reducing manual human error in data transformation, extraction, and population, but also producing and providing better access to real-time data for our public. You have also heard in last month about our chronic disease and injury data dashboard, which replaces the need to create written reports and saves our funds that we used to put into hiring external vendor. Every year we produce the written report. Another dashboard I would like to bring attention to that we haven't talked about is our CRO and CPO surveillance dashboard, as our team monitors antibiotic resistance for healthcare associated infections. This is an interactive and completely automated dashboard now created in collaboration between statistics, informatics, and the epidemiology program. And with the launch of this dashboard earlier on this year, we no longer produce written CPO topics for the public, and they can get real-time updates through just going to our website. And on the topic of antimicrobial resistance, we did publish also our 2024 Community Antibiogram, which provides information on clinically important bacteria and their susceptibility trends. And also happening just this month, we also published our quarterly communicable disease reporting and statistics for the first quarter of 2026. This series that we produce covers tables and figures to compare reported morbidity and selected communicable disease during the most recent quarter in comparison to the historical trends in the past 5 years. And we are currently seeing increases in this quarter in animal bites reporting. Animal bites reporting has been increasing continuously for us in the past 3 quarters. And to standardize and modernize our system and data tracking, on April 3rd, the EPI program did launch a new electronic portal for reports of persons exposed to rabies-susceptible animals. The advantage of this modernized system is not only to just empower our partners and residents to actively submit incidents for timely reporting, but also generates automated workflows and alerts to prompt public health follow-up as we benefit the communication and workflow between our partners in EHS and Washoe County Regional Animal Services. So the digitized information does reduce manual work as well and feeds standardized data into a live portal for tracking program indicators and other outputs that's benefiting the health and wellness of our communities. And that's all my updates. I'm happy to answer any questions.
Dr. Dow, that was a very comprehensive report. Thank you so much. Let's see if we have any questions from the board. Okay, nothing today. Thank you so much. We'll close out item 12D and move on to ODHO,
Thank you.
item 12E. Dr. Kingsley, do you have any updates for us today?
Nope, just as the report is presented to you, in just recognition that the answer from the from REMSA to Member Driscoll was provided as just an attachment in there, just documenting and acknowledging that that response was put there in my staff report. But other than that, open to any questions, but no further information on my report.
Okay, any questions for Dr. Kingsley? I wanted to say thank you to you also, Dr. Kingsley, today for the ribbon cutting at the TB clinic. Very well attended, a lot of media there. Thanks to Scott Oxerart also for organizing all of that. Very important, and I think for our region, sort of one of those things that we'll all look back on and be very proud. I'm grateful to the organization and for the opportunity to do it. I'm grateful for the county, for the land and the space where we are. And it's great. It was a building that was long overdue and sadly and sorely needed. The last building we used was built in 1959, and no public health facilities had been built in this region for the county since 1970, I think. So, and so it's very impressive to be there. So thank you for that and for your team. I'll close out item 12E and go to public comment. Madam Clerk.
Comments heard under this item will be limited to 3 minutes per person and may pertain to matters both on and off the board agenda. Unused time may not be allocated to other speakers. Comments are to be made to the board as a whole, and virtual public comment may be taken when facilities are available. A speaker's viewpoint will not be restricted. However, reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant statements, unduly repetitious statements, and personal attacks that would objectively antagonize or incite others are examples of speech that may be reasonably limited. This board carries out the business of Northern Nevada Public Health and its citizens during its meetings. The presiding officer may order a person removed if the person's conduct or statements disrupt the order or safety of the meeting. Warnings about disruptive conduct or comments may or may not be given prior to removal. Furthermore, certain disruptions of a public meeting are criminal acts as defined under NRS, which may result in prosecution in appropriate cases. And we do have one request for public comment. It would be Aaron Abbott from Technical Medical.
Mr. Abbott, welcome and good afternoon. Thanks for being with us here today. You get the award for longest being here in the audience. And thank you also for Public EMS Week.
Thank you very much, Mr. Chair. Mr. Chair, members of the board, for the record, Aaron Abbott, I'm the CEO and founder of Technical Medical. I'll preface my comments with I come from a place of respect and understanding of the difficulty of your positions, and thank you again for all of you who serve our community in the way that you do. But I also come from a place in an effort to try to better understand and hold public policymakers accountable. I think it's my duty as a citizen and my right as a citizen as well. On January 22nd, this board approved the REMSA franchise extension despite a laundry list of concerns from the vast majority of the board members. Those concerns are reflected into the 19 items that were discussed in Agenda Item 10. Not only were there serious concerns, and in fact, the comments that words matter, echo in my head from that meeting. And I'm not quite sure what words were actually approved. The deputy district attorney at the time also commented that that agenda item was up for a vote for approval or not approval. It was not agendized for direction or staff approval. That item ultimately passed with direction to staff and proposed changes to that item. Last month, Board Member Driscoll requested that item get put back on the agenda for today for reconsideration, and that request was not granted. Given that February's meeting was not a regular meeting, I'd like to better understand why that item was not placed back on the agenda for today. I'd also like to point out that item 16 on this list of items regarding airport transfer language, which attempts to grant exclusivity to the franchise holder, violates federal law and A letter from our attorney has been sent to this board explaining that law further. So if you all have not read it or seen it, that was sent on February 20th, and we've not received a reply from this board that it's been received or read. So I just wanted to point that out. And that's it. Again, thank you very much for letting me speak. Appreciate you all.
Mr. Abbott, thank you so much. And so that you know, I have read and received the letter that was sent. Thank you so
very
much.
Appreciate that.
Any other questions, Madam Clerk, or I'm sorry, any more comments from the public?
No other comments.
Okay, we'll close item 13 now and move to board comments. Any comments from the board? I'll look here. Okay, we'll start with Mr. Driscoll.
Mr. Chair, I will not be in attendance for the May meeting. And unfortunately, I will not be in a position to either call or Zoom in.
How
So I'm
lucky
just
you
going to
must be.
just be absent.
Thank you for letting me know that. Hopefully you'll be somewhere like Bora Bora or something exciting. Any comments over on this side? Mr. Anderson?
Yes, sir. Thank you, Mr. Chair. Actually, I didn't even think about it. The moment we were having the presentation there at the beginning, recognition of Drinking Water Week, May 3rd through the 9th, it wasn't until after the fact that I realized that that also coincides with Truckee Meadows Water Authority Smart About Water Day, which is May 9th. And I believe it's from 10 o'clock until 2 o'clock
Till 2.
at the California Building at Idlewild Park. So if you want to learn more about safe drinking water and water supply, that would be the event.
I love that. And I love that you've chosen the California building. Have you been there since we did the remodel of it yet?
I have not.
When did you do it?
We just did it. We did a ribbon cutting for it. It's a beautiful and stunningly remodeled building, and it's historically
Don't
been.
spill any water on the floor.
Oh, you'll be okay though, because there'll be lots of people spilling lots of stuff in there. It is a beautiful building. I can't wait for you to see it.
Good. Thank you.
Anything on the end there, Chief? Nope. Okay. I have nothing, and so this meeting is adjourned.
Very cool.